Good evening, everyone. Our faculty has arrived, and we are just waiting for our Honorable Minister, and we will begin the program in just 5 minutes. Welcome, Honorable Minister Shri Anupriya Patel ji. Please give a big round of applause. Yeah. Yes. I request all the dignitaries to come on the dais. Namaskar, good evening, esteemed colleagues, healthcare pioneers, and distinguished guests. Myself, Dr. Ram Prasad Dharangutti, on behalf of organizing committee, I welcome each and every one of you to second edition of Medharmony, a confluence of healthcare leaders. Welcome everyone. Please give a big round of applause. Let us begin this evening with a note of harmony and reflection, and begin this program with lightning of lamp. May I now request our honorable chief guests and distinguished dignitaries to come to the dais for the ceremonial lighting of the lamp, symbolizing knowledge, hope, and the collective commitment to advancing healthcare. Let us begin today's proceedings with playing of national song. I request all of you to please rise from your seats for our national song.
Shyaam Ram Mataram, Vande Mataram.
Thank you. Kindly take your seat. Good evening, everyone. The idea of Medharmony was conceptualized to bring together healthcare leaders from different specialties on a unique platform to dictate the future of medicine. And where else could it realize than the city of Pune, which is city of education, now becoming the city of healthcare excellence with over 16,000 beds across different multi-specialty hospitals. Before we chart the course for the future tonight, let us take a look back at the incredible foundation that we have built together. Exactly 1 year ago, here in Pune, we witnessed a historic milestone with the launch of Bharat's first truly integrative cross-specialty healthcare conclave. Medharmony 2025 brought together over 500 eminent medical consultants, visionary policymakers, and healthcare entrepreneurs from across the nation. Guided by the legendary voices like Dr. Nageshwar Reddy, Dr. Gurva Reddy, last year's deliberations culminated in 8 landmark decisions. We established a unified consensus that integrating artificial intelligence in clinical practice is imperative, and empathy-led collaborative care must remain the absolute bedrock of India's medical ecosystem. It was a resounding success that set a new benchmark for our fraternity. Building upon that momentum, Medharmony 2026 shifts its focus towards building resilient, systemic national infrastructure. Our overarching theme for this edition centers on a critical mandate: the new era of healthcare, accessible, affordable, and high-quality care. To formally welcome all the distinguished guests, may I now invite Dr. Aditi Karad, Executive Director, Vishwaraj Hospital, to deliver the welcome address. She is also the Trustee and Joint Secretary of Secretary General, Myers MIT Group, Pune, where her focus is on providing affordable healthcare and value-based education for one and all. Please give a big round of applause for Dr. Aditi Karad.
Thank you, Dr. Ram Prasad. Namaskar. On the behalf of organizing committee, I would like to welcome all the doctors and healthcare leaders of Pune for second edition of Medharmony. We are deeply honored to have Srimati Anupriya Patelji with us as our chief guest, Honorable Minister for State for Health, Family Welfare, for Chemicals and Fertilizers, Government of India. Her presence at Medharmony gives us the confidence that the conversations around policy, access, reforms will be heard earnestly. Welcome to Medharmony, Anupriya ji. Thank you for accepting our invitation. We are equally honored to welcome Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospitals, as our guest of honor. Dr. Reddy, I'm personally a great admirer of yours for your contribution towards healthcare and speeches. We also welcome warmly Dr. P.D. Shinoy, sir, former IS officer, former Secretary to Government of India, ex-member of NCDRC, Dr. Mahesh Baldavaji, senior pediatrician as the medico-legal expert. I still remember our first discussion with the organizing committee 1.5 years ago, when we were not entirely sure whether this idea would even work, because usually we have medical conferences. But over 500 doctors across all the specialties came together to first edition of Medharmony, and that gave us a quite enthusiasm that across medical conferences happens across India, but different specialties, policymakers, hospitals coming together and talking about healthcare, that's the need of the hour. Medharmony was never meant to be another medical conference, as I mentioned. It was built with a simple thought that the cardiologists, pediatricians, hospital administrators, policymakers, all trying to solve a different pieces of the same puzzle, but hardly come together. So that gave the birth to Medharmony. We envisaged a platform where all healthcare stakeholders could come together to engage in constructive dialogue to create a harmony for better healthcare system of our country. This is a real moment behind why this conversation matters now. India's healthcare sector today is valued more than 400 billion US dollars, making it one of the top 5 healthcare markets in the world. And this kind of growth brings a tremendous opportunity, but also important questions about who ultimately benefits from it and how. We are already seeing early signs of what this transformation could look like. AI systems that can identify diabetic retinopathy faster than the specialist, different algorithms that can help to predict cardiac event before the symptoms even appear. It is genuinely exciting, but it also means that the medicine as the next generation of doctors will practice it is going to look different from the medicine most of us trained in. Healthcare today stands at the far more complex crossroad than it once did. Policy on one side, technology and AI on another, and the patient expectations somewhere in between, and increasingly the question of trust running through all of it. Over the next few hours, we will learn from the experiences about how to deliver advanced medical clinical care while keeping it affordable, transparent, and how to practice medicine without fear. These may seem like different conversations, but they are connected by one common thread: the trust between the patients and the people who provide care for them. I do believe we won't be able to resolve all these challenges in one evening, but I do believe that when right people come together for honest conversations, progress happens much faster than we realize. Every meaningful transformation in healthcare over past decades began with someone starting the conversation long before it became policy or practice. I extend my heartful gratitude to all the healthcare leaders of Pune for coming together once again and helping to build this platform for the second consecutive year. The future of healthcare is incredibly promising, and it rests on exactly this kind of collective commitment. Once again, a very warm welcome to all of you to second edition of Medharmony, a confluence of change makers. Dhanyavad. Thank you. Namaskar.
Big round of applause for Dr. Aditi Karad. Thank you, ma'am. Those words beautifully set the tone for the evening ahead. Our next speaker has played a defining role in shaping modern Indian healthcare, and her topic is the new era of healthcare: accessible, affordable, and high-quality care. It is my privilege to invite Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospitals. I invite Shri H.C. Jahangir, Chairman, Jahangir Hospital, Pune, Trustee Sir Ratan Tata Trust, and Dr. Aditi Karad, Executive Director, Vishwaraj Hospital, to felicitate Dr. Sangeeta Reddy. Honorable Minister, Shri Anupriya Patel ji, felicitating Dr. Sangeeta Reddy. Please give a big round of applause, everyone. Dr. Sangeeta Reddy is amongst India's most influential healthcare leaders, steering strategic growth of Apollo Hospital, Asia's largest integrated healthcare network. With over 12,000 beds under her leadership, Apollo has pioneered digital health adoption at a national scale, encompassing telemedicine, AI-assisted diagnostic, and preventive healthcare platform. She chairs FICCI's Health Service Committee and has been a decisive voice in shaping India's national health policy. Her perspective uniquely bridges critical governance, institutional strategy, and patient experience, making her one of the most compelling voices on the future of healthcare delivery in Bharat. Please welcome Dr. Sangeeta Reddy.
Honorable Minister Anupriya ji, most dynamic and extremely committed organizing committee members, and especially Aditi, all of you wonderful audience, Namaste and good evening. Let me begin by saying that I am so truly impressed because in most cities, when we have healthcare conferences, we have administrator conferences, but they are primarily run either by one hospital or by the healthcare associations. There's FICCI, there's CII Healthcare Division, or there's Nat Health, and we run these. But the beautiful confluence, and the word itself says Medharmony. So all of you coming together, I want to congratulate Aditi and all of you who have put this together, Dr. Grant, every single one of you who made this possible, Dr. Sanshetty. It is such a messaging that we are here together to serve an extremely important purpose. I'm going to divide this. I'm going to speak a little fast because truly there's so much to say and so much to share. I will begin by saying that yesterday I was in Goa at the Nat Health Conference. And at the Nat Health Conference, I'm honored to be the president this year. We looked at one very important thing, which is that the critical role that healthcare providers have been playing and our ability to create a confluence or a partnership with the government to do more together is truly something. And I'm privileged to be sharing this thought in front of the Honorable Minister. One of the topics which is very much in all your minds is the whole concept of AI. The government has inducted Nat Health into a committee called SAHI, which is to create the ethical framework and the governance standards for the acceleration of the application of AI in healthcare. It's a powerful thing. If you look at the size and the volume of the National Health Authority, the number of lives they're covering, the claims they're processing, the data they're doing, and the fact, it's an amazing statistic, they are able to do 30% first-time auto-adjudicated claims. Can you imagine the impact of this? So when we asked, the CEO of NHA, saying, now tell us what you can do for the private providers, because we're having lots of problems with insurance. Our patients are waiting 6 to 7 hours before the insurer says okay. Very often they say okay, and then before the patient leaves, they're denying claims. And they're not able to keep pace with the new technology, so they say no to some robotics and yes to some other robotics and yes to Zap sometime. So how can we make this different? So now we're looking at the National Health Exchange for not just what you're doing on Ayushman Bharat, but also Ayushman Bharat, maybe potentially CGHS, I'm not sure, but also private providers, payers and providers coming together on NHX. So I just believe that there's a lot which is happening, and this is an initiative I feel very strongly about, because almost 11 years ago, when insurance was beginning, I spoke to the IRDA based on our US experience, that we should ensure that India has the lowest back-end per transaction cost compared to anywhere in the world. And why do I say this? Because for every rupee that we spend, we should not spend 17% on claims processing, back-end coding, all kinds of other processing. And every rupee should go directly towards medicines and provisioning. So this is a large vision of NHX, and I request all of you to become party to, either directly or through the Nat Health, so that you log into this, you help shape the positioning of this, and then move on. And then finally, the other, I think, very critical and important initiative is that we signed with Niti Aayog to create a framework for quality in India. And this is another important one, because when you ask the question of quality, affordability, and accessibility, the day all of us can stand up and say that this is not a choice, we want all three, that's the day that we've really positioned ourselves for universal healthcare. Because there is no reason why someone who lives in a village, so your healthcare quality should not be defined by the zip code in which you are born. So these are the broad things on Nat Health that I wanted to share, because I'm very inspired by so many providers coming together. With this, I'll jump into my presentation. Can I have a clicker, please, to go through the slides? And can I have the first slide? Yeah, thank you so much. Okay. This is forward? Okay. So we're talking about a new era in healthcare, which is accessible, affordable, and high quality. And we're also talking about a change which is happening of moving from bits, actually from beds to bits, but the bits which was the IT connectivity is actually moving to tokens, which is the language in which you're accessing AI. So this change or movement is happening real time in front of our eyes. And it's for us to really drive this change, shape this change, and figure out how we can make this happen. But to begin with, the power and the beauty is that we're all connected by one powerful mission, and that is to heal. So higher quality, a shared purpose, the concept of sustainable cost, accelerated cures are all being set in a background of the Indian demographic. And this demographic is the fact that, yes, India continues to have one of the highest out-of-pocket expenditures, but we are also a young nation with 43% of our population under 24 years, with over 118,000 doctors being produced every year, and a lot of credit to the tremendous medical colleges all of you have put up. We should give Pune a big hand for really catching up and now spearheading the university momentum. Every other person in this room says, yes, I have a medical university. It's very powerful. But just to say, I also want to congratulate the government, because the number of the incentive to push forward and create more medical schools, and the deregulation of the number of nursing, the number of seats you could take into nursing. We worked very hard on this for many, many years, and luckily that has changed as well, that we can double the number of nurses for the same infrastructure, and this is a need of the country, but it's also a need of the globe. And that's another theme that I will subsequently talk about. Coming to Apollo, really, our mission began in 1983. The idea, Dr. Reddy returned from the US. He lost a young man before he had enough time to go to the US for heart surgery. And that day he said, Indian doctors are capable of curing and healing people all over the world. Let us bring the infrastructure to India. So with this mission, today we moved towards 73 hospitals, over 12,000 beds, 25,000 advanced procedures across using various technologies, but also an omni-channel healthcare platform where you can do virtual teleconsults. And here we began our telemedicine journey in the year 2000. And actually that was when Bill Clinton pressed the button connecting my father's village with one of our high-end hospitals. We looked at over 37 million patient records. We connected with insurance, we created condition management, we looked at online medicine delivery and of booking services and said, this is the omni-channel path for the future, because in the beautiful line that Aditi said of rising healthcare costs, enhancing technology and AI, patient consumerism somewhere in the middle, but actually right in the center, the answers are not standalone facilities. The answers are not just high-end hospitals. The answers are connected ecosystems, all of which you either own or you partner with, so that you create a continuum of care from the first to the last. And then you look at the continuous cycle of even post-surgery. Because how do we measure quality if we're not checking what happened to our patients where we did a fantastic bypass surgery, but what was their survival rate 3 years after if he went back to his village in Agartala? Are we tracking PROMs? So there are many of these questions which we need to accelerate, and digital connected care is really one of the methodologies to bring this together. Another clearly important one is AI. I pulled up this slide very quickly in the last minute because I was told that all of you are very interested in this. And I want to say that we've looked at AI across a few different work streams. Our first and our most important one, work stream one, is CIE, which is the Clinical Intelligence Engine. This is our CDSS, Clinical Decision Support. So how do you ensure that 12,000 doctors across 73 hospitals and 300 clinics are following your pathways? How do you ensure that they are giving the best of care? And how do you sleep at night if you're not worried about this? The methodology clearly is to use digital to encapsulate. So here what we're doing in the clinical intelligence engine is sitting next to the electronic health record, not dictating to the doctor, but suggesting and prompting. You've chosen this protocol, or you've chosen these 5 tests and these 2 medicines. Would you like to consider? Would you like to collate? And at the back end of this, we have not only clinical protocols, access to OpenAI and Claude, but also our own drug-drug interaction engine, which we've built ourselves based on Indian pharmaceuticals' amazing capacity to make cocktails. And they mix all kinds of compounds, so we had to create our own drug database. And therefore, this flags if there's a drug-drug interaction, because when you have 5 super specialists coming, seeing the patient and writing a prescription, have they often checked what the first doctor was giving? These are the critical things where technology is your transformer, technology is your enabler, and technology is also your peace of mind. But also it's not your dictator, it's just your assistant. Keep it as an assistant, don't let it dictate. So that's the CIE. Our second one is the disease progression and risk scoring methodologies. In a population, how do you see who has higher cardiac risk? This was our first algorithm created almost 7 years ago in partnership with Microsoft, and now this is being used across many locations. Our next very important one is image signaling, and clinical pathways. So early detection of TB was done, but now looking at early brain bleeds. So your patient moves from the emergency room if he has a bleed into the theater even before your radiologist has seen it, because he will revalidate before you open the patient, but you've prepared the theater and kept things ready. This speed saves lives. This ability to prompt ensures that you do not delay for the doctor to come the next morning and then take a decision whether you're operating or not. So this is a whole stream, and we have almost 19 different protocols, 7 of which are already MDSAP approved, and 2 of them are in the FDA pathway. We also have, and I'm very proud of this one, we have an embedded AI into the ultrasound. This is not yet in daily use. But imagine if an AI could sit inside the probe of the ultrasound and pick up NAFLD. 40% of the adult Indian population is at risk for NAFLD. If you don't pick it up right because the ultrasound technician isn't perfect, or for whatever reason the patient didn't go there, you then find the patient in end-stage liver disease. So this is the difference between early diagnosis and the course of treatment. We also look at acute care augmentation, early detection of sepsis, better antibiotic prediction, a range of things across this. And I'm very happy to share this one slide. I will mail it to Aditi so that anyone who wants to see it or learn more, because we are pressed for time. Just to say 3.5 million API calls have been on this, and also that we do all our AI in what we call the EASE, or the ethical framework, which looks at ethics, suitability, adoption, and explainability. If you can't explain in one line why you're doing AI, it's not worth doing, and no doctor is going to pick it up. So this is the very simple framework. I want to move very quickly to another very important aspect of what we do, which is called ProHealth. I believe that we are in the era of proactive preventive healthcare. We do approximately 4 million health checkups. We have about 145 centers. We've created a unified platform, and I'm happy to say that this platform is now being used in countries outside of India. In Indonesia, we have introduced the ProHealth platform, in Bahrain as well as in Dubai. I believe that this methodology matches another important concept I'm going to talk to you about. But there are 3 of them, so I'll tie them all together at the end. But just to say how, if you do this, transforming health, because 60% of the current disease burden in India is lifestyle-related disorders. If we can pick them up early and transform the way care is delivered, you will reduce the burden of disease, and you will create a healthier population. And like we told the Honorable Health Minister, you cannot have a Vikasit Bharat without a Swasth Bharat. These are details of how this model validation happened. What is the clinical AI pathway? What is the accuracy rate? what is the Bayesian model of learning and outcomes, and how we ensure. And the reason I'm showcasing this is that all AIs are not alike. When you're adopting an AI, please ensure that it has an adequate size, an adequate number of the appropriate population has been covered, and it's been validated against. Otherwise, if you present it to your doctors, you will lose the credibility of AI by using inappropriate AI, because today we don't have a governance model for AI. Finally, I want to move to the concept of teleradiology, telepathology, and telemedicine, because while we can do it all over the world, why can't we do more of it across every Indian village? Imagine if every village, and we can afford to have, now we're manufacturing in India, if we had a CT scan in every Indian village, would the diagnosis of cancer be different? Every time a cardiologist sees a 5-vessel disease, he's wondering in his heart, what happened when that first vessel got blocked? Why couldn't I do a disease prediction or an early health checkup? In cancer, it's a little more complex, because while today people are doing blood tests for circulating exosomes and picking up early biomarkers, it is not yet a complete science. But a CT or an MRI and a combination of a good physical exam could pick up cancer. So can we as a country have an ambition that the current number of cancers that we find in stage 3 and 4 are upwards of 70%? How can we make sure that 70% of the cancers we find are at stage 1? Early diagnosis, preventive care, and access to healthcare is really that transformation. And this can be done. We should do it. I want to add one more of this changed pathways which embeds AI, but talks a bit more. And this is our whole pathway from an ER in an international hospital to the CT imaging in that hospital, to our hub sitting in Hyderabad where we analyzed, and then the radiology reviewed and said, this is the neurological status, you go into a stroke protocol. So this is the third thing I wanted to talk to you about, and now I'll reveal the suspense based on Saipan Island. There are 3 very important aspects that we had the privilege of speaking to the Honorable Prime Minister. The first one is Heal in India. Medical value travel is transformational. The second one is Heal from India, which is remote care, like I told you in Saipan. And the third is Heal by India, so that the doctors and the nurses and the technicians you're training can help to mitigate the 17 million global shortage of healthcare workers, because India brings 10 million young people into the workforce every year. How many of them can we channelize into healthcare to help heal the world? Imagine a young India healing a graying world as the older generation increases in Japan, in the US, in Europe. How can we take our young people across the world? So please remember, Heal in India, Heal from India, and Heal by India. And technology is one of the enablers, and partnerships is the other. I want to just add this one. Can I get this video?
At the heart of every life-saving decision is a team of medical specialists committed to patient care. But for many clinicians, valuable time is lost hunting for patient data across fragmented systems. Microsoft and Apollo apply today's technology to solve this critical problem. The Clinician Copilot, designed to serve the needs of healthcare professionals, generates a holistic picture of each presenting patient, quickly delivering the information clinicians need to inform the right course of action. As technology continues to revolutionize the medical industry, we imagine a future where AI-driven diagnostics could predict illnesses long before symptoms appear, where treatments are tailored to each individual's genetic makeup, where virtual reality accelerates training the next generation of doctors. A future where patient care is not just reactive, but proactive.
So thank you. This is just one case study of how we're putting this into application. I also believe that AI-enabled command centers will help individuals with larger ecosystems Today, we're handling over 1,500 ICU beds outside of an Apollo ecosystem. These are small nursing homes. These are PSU hospitals who say we have 5 ICU beds, can your experts manage them? This is the way that I think we will ensure. Remember, we spoke that cost, quality, and access, we can achieve all 3. This is how technology will enable us to achieve all these together. And this has clinical wins, it has human capital impact, and it has real patient impact from a number of lives saved using this technology. This slide is really about how we can work at small community levels. We run about 2,600 government PHCs using telemedicine technology and connected care. We do digital clinics, we do mobile units. So I think finding ways to take this knowledge and data, put it into innovation, research, and clinical trials, bring new cures for the country, and activate a better level of care is really what healthcare is all about. I believe the hospital of the future is going to look very different from the hospital of today. We recently, day before yesterday, inaugurated the ICU of the future, where every single equipment was connected to the EMR, is connected into the command station, and is back-ended with AI for the early warning symptom, the infection control rate, and has the telemedicine connectivity if you want a second opinion. So if you want a doctor to come and see, you don't have the nurse or the doctor calling up 5 times saying, please, I want a neuro consult, I want a gastro consult. You click the button, you connect him in his room, you showcase the reports which are there, you get his opinion right there, under 15 minutes. So this speed and efficiency and this connectivity, whether it's a smart ambulance where you start treatment, it's a smart theater where you're viewing all your reports, and it's an AI embedded backend where you're analyzing every care protocol, but most importantly, every deviation from your protocol is being analyzed not retrospectively as a quality, but real time so you can correct it right there. This is the hospital of the future. This is what India can create together. And this is ambient, intelligent loop that you can embed into your systems. So this is what we're beginning to work on. I don't think we're completely there, but it's an amazing and a fascinating journey. And I'm happy to look out for partnerships and ways that we can work together to bring our data together interestingly. Finally, this is my last concept, which is the Healthyomics flywheel. If you use your data right, if you focus on prevention and bring that data, if you scale your infrastructure so that every village, every town has the core infrastructure, if you connect it into your digital backbone and your knowledge system, and then you look at global services, India will stop being a country where healthcare is a line item on the budget and 2% is allocated, and 3% comes from out of pocket and other sources. Healthcare will become a revenue generating item. Healthcare will begin to be looked at a productivity generating item. So like I said, Swasth Bharat is equal to Vikasit Bharat. Let's all stand up there and stand together like this conference Medharmony says. Let's do it together, and this will be the transformation that all of us are looking for. And we move from ill care and high-end care, which is fantastic, and we have to do it, to well care and keeping people well and healthy across, whether you're using Ayurveda or preventive healthcare tools. Finally, I must say that the technology is ready. Other industries are using it. We need to run faster than everybody else to make sure that we catch up and ensure that we build a healthy country together. Namaste. Let's co-create the future of healthcare. Thank you.
Please give a big round of applause for Dr. Reddy. Your thoughts remind us that quality, accessibility, and innovation must always progress together. Thank you, Dr. Sangeeta Reddy. Now we move on to one of the highlights of today's program. I'm sure you are eager to hear from Honorable Minister. Before welcoming our Honorable Chief Guest, may we present a brief audiovisual introduction.
Srimati Anupriya Patel, Union Minister of State for Health and Family Welfare and Chemicals and Fertilizers and Member of Parliament from Mirzapur, Uttar Pradesh. A respected leader at the forefront of public policy and healthcare, she has represented Mirzapur in the Lok Sabha since 2014 and serves as the national president of the Apna Dal, Sonelal. Having first served as Minister of State for Health and Family Welfare from 2016 to 2019, she now returns to the portfolio with extensive experience and deep institutional insight. Her leadership extends well beyond India, having represented the nation at major global forums. She has addressed the United Nations on ending AIDS through revitalized multilateralism, spoken on antimicrobial resistance at the United Nations headquarters in New York, and led India's delegation to the Global Ministerial Conference on Antimicrobial Resistance in Jeddah. Alongside her healthcare portfolio, she also serves as Minister of State for Chemicals and Fertilizers, supporting initiatives such as India Chem 2024. Her vision continues to shape India's healthcare landscape, making her insights especially valuable to today's gathering. Ladies and gentlemen, please join in extending a warm and enthusiastic round of applause as we welcome Srimati Anupriya Patel to the Medharmony stage.
Ladies and gentlemen, please give a big round of applause for Honorable Minister. I request Dr. Rahul Vishwanath Karad, sir, an eminent educationalist, the man who started first college to develop future politicians of Bharat, to felicitate Dr. I also invite Dr. P.K. Grant, sir, Chief Cardiologist and Chairman of Cardiovascular Services, Managing Trustee, Ruby Hall Clinic, to felicitate Honorable Srimati Anupriya Patel ji, Minister of State for Health and Family Welfare, Government of India. It's my proud privilege to invite our chief guest, Honorable Srimati Anupriya Patel ji, Minister of State for Health and Family Welfare, Government of India, to deliver the keynote address.
Dr. Rahul V. Karad, Executive President, MIT World Peace University and founder, NLC Bharat. Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospitals. Dr. P.D. Shenoy, former Secretary to Government of India and ex-member NCDRC, also a medico-legal expert. Dr. Mahesh Baldava, Senior Pediatrician, medico-legal expert, Mumbai. Dr. Aditi Karar, Executive Director at the Vishwaraj Hospital, Trustee and Joint Secretary General, the Myers MIT Group, Pune. Dr. P.K. Grant, Chief Cardiologist and Chairman of the Cardiovascular Services and Managing Trustee, Ruby Hall Clinic, Pune. Dr. Parag Sancheti, CMD of Sancheti Hospitals. Dr. Ankit Thakkar, MD and CEO, Jupiter Hospitals. And all the distinguished members of the medical fraternity and from the healthcare industry who are present here today, all the distinguished participants, eminent guests, a very good evening. I have great pleasure in joining you all for the second edition of Medharmony 2026. And it's a platform that has brought together, as I'm told, a large number of doctors across, say, over 50 specialties. I congratulate MIT World Peace University and all the other partner institutions for this initiative, for creating this very unique forum where you bring together not just the policy makers, but also medical professionals, leaders from the healthcare industry, academicians, researchers, everybody, all the key stakeholders together to discuss on the future of healthcare in India. Health, we at the Health Ministry firmly believe that it's a shared mission. And government's efforts have to be complemented by every other key stakeholder. So this is a goal which requires the collective wisdom and the commitment of every other key stakeholder. And I believe this forum gives us an opportunity to share our perspectives and make a commitment towards fulfilling the larger national goal of building a healthier India, and through a healthier India, a developed India by 2047, when we complete 100 years of our independence. I'm very happy to be here today in Pune because it's a historic city where Mata Savitri Bai Phule ji, she established the first school for girls, and Dr. Anandi Bai Joshi, she inspired generations, becoming the first woman physician of India. And there could have been no better place than this to organize a conclave like this, have a conversation on healthcare in this city. So it's very befitting that we are all meeting at this very historic place. I'm glad the theme chosen for today is accessible, affordable, and quality healthcare. Friends, world over, healthcare is undergoing rapid transformation. And we're seeing a shift from treating illnesses to preventing and promoting good health and well-being. We're seeing a shift from fragmented care to integrated systems. And we're also seeing a shift from reactive responses to proactive responses to prevention and technology-driven healthcare. Today, when you look at India's new health policy, it talks about accessible, affordable, and quality healthcare. And for us, this is not a political slogan. Universal health coverage has been talked about time and again by subsequent governments. But this government has decided to convert universal health coverage into a reality. And we're doing everything which is required to achieve this objective. And the first of the step that we have taken is to increase public spending on healthcare. The National Health Policy provides a direction for taking public healthcare spending to around 2.5% of the GDP. And this policy was rolled out in the year 2017. That was also my first tenure as MOS Health. I saw this policy being rolled out. And since then, we have been gradually increasing our expenditure on health. And today, we are close to around 1.9% of the GDP. And we will be coming closer to 2.5% of the GDP with the rate at which the health budget allocation has been increasing year after year. Government intends to bring down the out-of-pocket expenses for every ordinary citizen, and keeping that in mind, several initiatives have been launched. The most important ones, the flagship initiative is the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. And today it is becoming an instrument of social transformation. There were millions of families who would be pushed down poverty because they did not have enough financial resources with them to treat a family member. But today, Pradhan Mantri Jan Arogya Yojana, a scheme which has offered a big financial safety net to 62 crore Indian population, has been able to help these families in seeking treatment, in seeking institutional care. And so far, since the time this scheme has been launched, more than 12 crore Indian citizens, and majorly those who belong to the low-income households, they have sought treatment worth 1.82 lakh crore rupees. So this much of amount has been spent by Government of India, which means public money is being saved and people are seeking treatment, and we are able to reduce mortalities. Likewise, our initiatives of providing affordable drugs, surgical implants, through initiatives like Amrit Pharmacy Stores or Jan Aushadhi Stores, these have also today given relief to a large number of patients across the country. And thousands of crores of public money has been saved because people can today get these generic drugs or branded drugs or surgical implants. They can get it at much lower cost through these stores. Pradhan Mantri National Dialysis Program, that's another very important initiative, which is providing free of cost services to any citizen of India at every district hospital on a PPP mode. And there are many such initiatives. which are helping our citizens today in bringing down the out-of-pocket expenses. And besides this, to attain the objective of universal health coverage, to ensure that every citizen in India has access to good quality and affordable health care, we've also been strengthening our medical education infrastructure. And that's why in the past 12 years of our government, you will see a massive increase in the number of medical colleges that have come up. 12 years back, when our government took over, we had only 387 medical colleges in this country. But today, we have 820 medical colleges. We have more AIMS which are being created. So having an All India Institute of Medical Sciences in a state is today the aspiration of every chief minister. We had only 7 All India Institute of Medical Sciences 12 years back. But AIMS is such a cherished brand that every chief minister wants that they must have an AIMS in their own state. And that's when we started building more AIMS. We added 16 more new AIMS, and today we have 23 All India Institute of Medical Sciences in our country. And not just doctors. Yes, we are increasing the MBBS seats, we've increased the PG seats, more than double. Prime Minister recently announced from the Red Fort that we'll be adding another 15,000 seats, which will have both UG and PG seats. But besides creating doctors and specialists, we also want to have more nursing professionals. We also want to have more allied healthcare professionals. And if you heard the recent budget announcement, it was about creating more multi-skilled caregivers in times to come, especially to cater to the needs of our aging population. So manpower shortage should not be an issue for this country. That's the idea with which the government is working today. We have scaled up our infrastructure because we want to increase our pool of medical health professionals. And besides this, digital interventions, digital tools and technology. India is today emerging as a leading nation in terms of digital interventions. Considering the size of our population, considering the challenges that we have in terms of the geographical diversity and other complexities, and the manpower shortage that we face, and we have been facing it over the years, we've decided that we will make utmost use of technology so that every citizen of India has access to good quality, affordable health care. And several digital interventions have been made. Today, an intervention like eSanjeevani, the National Telemedicine Network, millions of consultations have been done. An ordinary citizen who may be sitting in a remote location in a village can actually seek a specialist consultation through the National Telemedicine Network. This was not possible a few years back, but today it is happening. Technology is increasing access to good health care to every citizen in this country. And Ayushman Bharat Digital Mission, that's India's initiative to create a unified, interoperable digital ecosystem. And every single citizen of India today has a unique digital identity. You'd be happy to know that we've already created more than 95 crore Abha IDs and more than 100 crore medical histories, medical records have already been linked with these IDs that have been created. And simultaneously, there are different registries. We are creating a registry for our health professionals. We are creating a registry for our health facilities, which means every hospital, every clinic, every diagnostic center, every pathology, everything is going to be a part of a digital ecosystem. More than 10 lakh doctors across this country are onboarded. Now they have a verified digital identity, and we are appealing to all the doctors. There are so many doctors sitting in front of me. I would like to appeal to each one of you that Ayushman Bharat Digital Mission, it gives you that opportunity. And you must register on the healthcare professionals registry. It is a win-win situation for both the patient and the doctor. The patient, by creating an Abha ID, does not need to carry his medical records anymore to one facility and to another facility and across different healthcare providers. He can securely access his documents whenever he wants, wherever he wants. And doctors today, when they have a digital identity, they are discoverable for any citizen. Anywhere, any patient is sitting in any part of the country and looking for a specialist, then he can find a doctor who is on the health professionals registry. So that's the kind of ecosystem we are trying to create. And it is going to bring a big revolution in India's healthcare delivery. We understand that today, India has a dual burden of both infectious diseases and also non-communicable diseases. We also have the world's largest younger population, but at the same time, our elderly population is also increasing. And by 2050, it's expected that our elderly population may constitute 20% of our total population. So when we are thinking about the future of healthcare in India, we have to think about how to keep our youth population healthy and how also to take care of our elderly citizens. Today, we have a network of more than 184,000 primary healthcare facilities called the Ayushman Arogya Mandir in this country, which is the first point of contact for any patient. And we want to reduce the burden on our tertiary healthcare facilities. So these Ayushman Arogya Mandirs are today, they have been transformed completely. They are today providing a package of 12 different services, primary healthcare services to every citizen. And they've brought healthcare access closer to the communities. And at these Ayushman Arogya Mandirs, we are executing one of the world's largest population-based screening program to fight the alarming rise of non-communicable diseases. Every individual in this country who's aged 30 years or above is being screened at an Ayushman Arogya Mandir for diabetes, for hypertension, and for 3 types of common cancer. Women are being screened for oral cancer, for breast cancer, for cervical cancer. And so far, since the time we started transforming these Ayushman Arogya Mandirs and we introduced this package of 12 different services, there are 16 crore women in this country, especially the ones who live in the rural, remote locations, who come from the poor income households. They have been screened free of cost for breast cancer. 9.5 crore women have been screened for cervical cancer and diabetes, hypertension. Today, this screening is helping us to make timely referrals and treatment. We will be able to reduce mortalities. And at this Ayushman Arogya Mandir, we are offering nutrition and wellness counseling. So we are talking about health promotion and well-being, adopting a healthier lifestyle. Because we want our people to be healthy. And NCDs have become a major challenge for us. We are running this whole program, the national program, on prevention and control of NCDs, under which we are scaling up infrastructure, we are increasing our manpower. But this particular initiative where we have started screening people, that will have a major impact. And NP-NCDs has now, it includes a wide array of diseases. So it is not just the core illnesses, but large number of diseases have been included under this. And today is also an opportunity for me to appeal to each one of you, since I have such a distinguished medical fraternity sitting in front of me, that you have to cooperate with us. Government efforts are never enough alone. And NCDs are a pressing health challenges of our times, globally and for our own country. And you doctors can make a huge difference. Your advice, your recommendation, and your communication with the patient matters. So for every doctor who's sitting here today, I would say that every interaction that you have with the patient, that's an opportunity for you to make them aware about adopting a good lifestyle. We know how rapid urbanization, sedentary lifestyle, high stress environment, and the dietary changes that have taken place, all that is contributing to NCDs. But as a doctor, whenever you interact, each one of you must be doing so many consultations every day and so many patients you must be coming in contact with. So to help Government of India to be able to address this challenge of NCDs, we will need your cooperation. It is important to educate the general public about the dangers of NCDs and how our lifestyles, our dietary habits, our stressful environment, how it is contributing to NCDs, and what simple behavior modifications or lifestyle changes can make a huge difference. So that is my appeal to you today, to contribute to this mission, because NCDs have become a major concern. And besides NCDs, antimicrobial resistance. That's another very challenging task ahead. Government of India, Ministry of Health and Family Welfare has drawn up an entire national action plan. And we are doing what's required. But then, like I said before, health is a shared goal. So no healthcare target can be complete without the contribution of every stakeholder. And you're the biggest stakeholder. Antimicrobial resistance, today you would agree that it's like a silent pandemic. And there could be nobody better than the doctors themselves to educate a common ordinary citizen about the judicious use of antibiotics. In fact, you have to promote rational prescription of antimicrobials. We see general people, what they do, they will self-prescribe. They will start consuming some antibiotic, they will not complete the duration of their course. So who will educate them? It is you, the doctors, who have to educate them about the dangers of misuse, overuse, inappropriate use. And I want you all to prioritize this in your own hospitals, clinics, whatever you're running, infection control, that should be strictly monitored. And you also have to keep abreast of the local resistance patterns that are developing to improve the use of antimicrobials in your hospital settings. That's another appeal I wanted to make to you. And the third important thing, we've recently rolled out HPV vaccination for our girls aged 14 years. We've identified a cohort of 1.2 crore girls, and this vaccination is going on free of cost to all the public health facilities. It's picked up very well. We're seeing a very encouraging response. Around 50 lakh girls have already been vaccinated. But in some places, we do have vaccine hesitancy. And doctors, they are the best medium. You're the best instrument to address this vaccine hesitancy. Your guidance, your advice, your persuasion, that will make a huge difference. You can convince parents why girls need HPV vaccination and how harmful, how dangerous to life is cervical cancer, the second most common cancer which is taking away the lives of so many girls, so many women in our country. And India needs more and more physicians to come forward and strongly advocate for HPV vaccination to fulfill our vision of creating a cervical cancer mukt Bharat. You can play a very important role here. And that drive is going on. We're sure we'll be able to achieve our target. But when you lend your support, the process becomes faster, easier, more convenient. So coming back to universal health coverage, we're increasing our public spending. We've rolled out schemes to bring down the out-of-pocket expenses. We are expanding the medical education. We're also strengthening our infrastructure, fixing up the gaps that exist. COVID-19 pandemic had exposed the gaps that exist in our secondary healthcare infrastructure, in our tertiary healthcare infrastructure. And government specially launched the health infrastructure mission, which is called the PM Abhim, which solely addresses this concern. In order to be able to create a resilient healthcare infrastructure, to be able to face any pandemic, any future health emergency, we need to strengthen our secondary healthcare infrastructure. So today, if you go to any district hospital, you will see that a block public health unit is being built up in a sub-district hospital. Integrated public health laboratories are being set up in district hospitals. And why are we doing this? Because we don't want dependence to remain on metropolitan labs. We want to shorten the diagnostic turnaround time. So we will be able to respond to disease outbreaks better if we have such systems. Critical care blocks are being built up in district hospitals so that this kind of segregation is brought about. So when there is an emergency, the routine services do not get disrupted. That is how government is trying to build a resilient and future-ready healthcare system. We started a new mission, One Health Mission. That is an integrated approach. Human health, animal health, environment health, everything is together. And we bring together all of this because we want to respond better to the outbreaks. We want to prevent the outbreaks from spreading by way of collaboration, by coordination, by sharing responsibility. And these are huge missions which are being undertaken. And public-private partnership, of course. When I talk about a scheme like Ayushman Bharat Pradhan Mantri Jan Arogya Yojana or Jan Aushadhi Kendra or Pradhan Mantri Dialysis Centers, so many of the private players are coming together with the government. We have more than 36,000 hospitals which are empaneled under the Pradhan Mantri Jan Arogya Yojana. And a large number of facilities are the private sector facilities, which are empaneled and which are providing services under the scheme to a large number of patients. More than 12 crore patients have been treated, so they've not all been treated in government hospitals. So many of them have been treated in private hospitals. And there are so many ways in which governments and private sector are coming together today to strengthen the healthcare system in our country. The global uncertainties which we have been seeing for past few years, COVID onwards, so many. Sometimes there is a war in this part of the world, sometimes there is a war in some other part of the world. So we realized that we can no longer be dependent on any other country for our healthcare needs. It's more of a strategic necessity. And that's when we decided that we will launch a dedicated scheme to produce APIs in bulk drugs in our country, to make our own medical devices. And we have PLI schemes in place which are doing very well. They're slowly picking up. So many medical devices which we earlier never made in India, today we are making them in India. And we are also strengthening our regulatory mechanism to make sure that our medical devices meet the global standards. A large number of APIs are now being produced in India by our own pharmaceutical companies. Health research is being given a lot of push. Large number of health research projects are being funded by the government. And in the latest budget, a very important announcement was made about the Biopharma Shakti mission. We've long been the pharmacy of the world, supplying generic drugs, affordable drugs, vaccines to so many different countries. More than 200 countries we've been supplying drugs to UNICEF, to WHO. 70% of the vaccine requirement is fulfilled by India. But now our pharmaceutical companies they're slowly wanting to enter a new area. So they want to enter into biologics and biosimilars. From small molecules to large molecules, from volume-based generics to value-based innovations. And governments has the aspiration to make India a global biopharma hub. And Biopharma Shakti mission has been launched with the intent to boost the domestic manufacturing of biologics and biosimilars and make India a global biopharma hub. We want to capture 5% of the global biopharma innovation market by launching at least 100 homegrown biologics by the year 2047. So there is a lot which is taking place at the healthcare end. I'm glad I'm here with you all today. There is so much that we can do together. And as doctors, as medical professionals, your experience, your feedback means a lot to us. It is really valuable. And I would appeal that you keep partnering with the government, because your feedback will tell us about the strengths and the weaknesses that exist in our schemes, in our programs, or in other forms of initiatives, the policy initiatives, the interventions that we make. Whatever we do here sitting at the ministry, the only question that we always ask ourselves before making an intervention is, how is it going to affect and change the life of an ordinary citizen? And then if that intervention is able to answer that question, that's only when we proceed. And that is the ultimate aim of universal health coverage. I want you to partner with us and let us all work together to build an India which is healthier, which is stronger, because only then can we fulfill the national aspiration of being a developed India by 2047. Once again, I congratulate you all for this conclave. I hope this day-long deliberation, I don't know, it is 1 day or 2 days? 1 day. So lots of insights and valuable ideas will come that will show the way how to bring a better future of healthcare for India. Thank you, MIT World Peace University team, for having me here. And thank you all for being a patient audience. Jai Hind.
What a wonderful speech. Please give a big round of applause to Honorable Srimati Anupriya Patel ma'am. And we thank you for giving your valuable time to address the gathering. Now I request all the panelists and distinguished guests to come down at the front row so that we can have a photograph with all the delegates. I'm sure all of us want a photograph with the minister. I request all of you to rise from your chairs and hold hands of the person next to you to create the iconic photograph depicting solidarity and bonding between different specialities and commitment towards world-class healthcare. The photographer will take the picture from the stage. Thank you, everyone. Just a couple of minutes before we begin our next session, a panel discussion. Ladies and gentlemen, we now arrive at the most interactive session of the evening. The topic for today's panel discussion is Rethinking Private Healthcare, Trust, Transparency, and Transformation. I request all the panelists to join the stage.
I would request all the delegates to please be seated. Ma'am has a flight to catch, so she's leaving. But she has promised me that she's going to come again and answer all the questions we have for her. And she said that we should leave something for next time. So please be seated. We're going to have a very interesting panel discussion now. And this panel discussion is going to all be about what ma'am has just spoken to us and about affordable, accessible, and high-quality healthcare. So please be seated, and we will be starting in exactly 2 minutes.
The panelists for today's discussion are Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospitals, former President, FICCI. Dr. P.D. Shenoy, sir, former Secretary to Government of India, ex-member NCDRC, a medical legal expert. Dr. Shenoy also holds a rare distinction of dual credentials in both medicine and law, establishing him as one of India's foremost authority on medical legal affairs. The next panelist is Dr. Mahesh Baldava, Senior Pediatrician and Medical Legal Expert from Mumbai. Dr. Baldava uniquely combines active surgical practice and deep expertise in medical litigation and legal risk advisory, making him distinct authority in medical legal space. The next panelist is Dr. P.K. Grant. He is the Chief Cardiologist and Chairman of Cardiovascular Services and Managing Trustee, Ruby Hall Clinic, Pune. And the last panelist is Dr. Ankit Thakkar, Managing Director and CEO of Jupiter Hospital. He leads Jupiter Hospital's growth to a listed multi-city quaternary care group in Thane, Pune, Indore, and Dombivli, with new projects underway, including BKC Mumbai, taking capacity to 3,000 beds. He's also a master from London School of Economics and Harvard Business School for managing healthcare delivery program. He also serves on Nat Health's Governing Council and CCI Health Subcommittee. The moderators for today are Dr. Parag Sancheti, sir, Chairman and Managing Director of Sancheti Hospitals, Dean and Professor of Sancheti College of PG Studies, and our very own Dr. Aditi Karad, Executive Director, Vishwaraj Hospital, Trustee and Joint Secretary General, Myas MIT Group, Pune.
So thank you very much. We'll just start in a few minutes. I think Dr. Aditi has gone off to see off the Honorable Minister, but I just quickly want to ask Dr. Sangeeta her thoughts on such a passionate speech given by an Honorable Minister about, the PMJY, the scheme which he spoke, the Ayushman Bharat. So very quickly, and then we have a formal set of questions. But now, since everybody is kind of taken up by that speech, I would just want to know your comments. What does Apollo Hospital, and then we can ask Ruby Hall, what do you think about this, Ayushman Bharat PMJY scheme?
So, when we first started, we said that Indian healthcare has to be like the Indian railway. You need the air-conditioned coach, you need the 3-tier, you need the 2-tier, you need the non-air-conditioned, and everyone will reach their destination. So I think Ayushman Bharat is a reflection of the demographic of India.
Right.
Very honestly, I'm very proud that we played a role in the creation of universal health insurance.
Yeah.
In my father's village in the year 2000, 26 years ago, we did universal coverage of the village for 1 rupee a day. We took that knowledge of data pooling and population coverage and covered 3.5 lakh people of the Andhra police. We then covered the Karnataka milk farmers, 6 lakh people, came back and gave this scheme concept and workings to the Andhra government for Arogya Shri.
Correct.
Where for the first time a whole state had this coverage. Right. And that was the basis for Ayushman Bharat.
Yeah, so already there is a trajectory and there's some thought process which has come from
absolutely.
the Apollo group for that.
But I just want to say one last thing, which is that we all as providers here need to figure out how we manage the low prices and the expectations on us. That is the reality of the situation.
Yes.
And we need to create a framework for differentiation of quality, because if you're spending 1 to 2 crores per bed and your reimbursement is at the rate which it is, then you're not going to have a sustainable organization. So we must begin to introduce the word sustainability, a cost-based framework on reimbursement and a quality differentiation, and then talk about reimbursement, whether it is Ayushman Bharat or even CGHS.
Yeah. So, Parvez, very quickly, if you can just say in 2 or 3 lines, we have many other questions to follow. Just what do you think of, if the government does make it compulsory tomorrow for all of us to take it, what do you think about it?
Let me just talk a little bit about the Ayushman Bharat
you have only
scheme,
1 minute.
because it's very important. See, this scheme, let's be very clear that this type of scheme is very difficult to work.
No, he just started answering.
Cities.
Don't ring the bell. Wait.
It's very difficult to work in larger cities because the cost of running each bed is very high.
Yeah.
So this scheme is fantastic for smaller cities. Like at Ruby Hall, what we do, we have kept this Ayushman Bharat scheme in my Shirur hospital because the running cost is low.
Absolutely.
And we can afford to run it there. But if we run it in larger hospitals like Bombay, Delhi, Calcutta, it's not going to work at all because the cost is so low that it will not pay for the hospital to run that bed.
Yeah.
So I think it's a very good scheme for the rural area. It's a fantastic scheme for smaller towns. And if you really see, if you go just outside Pune, say 30, 40, 50 kilometers away, most of the hospitals, 90% are running on the scheme.
Yeah.
And they're surviving on the scheme. If it's not for the scheme, these hospitals will all close down. So basically, it is a fantastic...
So I think Dr. Parvez has answered it very well. Like it should be differentially launched.
Yes.
Maybe different things in the city. And if at all they want to launch in the city, maybe the prices just of 5 lakhs is never going to cover it. You know, that leads me into the next question, which I really want to ask you. The whole theme today is about accessible, affordable, and high-quality healthcare. Now, if today in Jupiter Hospital or Ruby Hall or Apollo, we want to do really a high-quality surgery, how does one make it affordable? So if you see anybody coming to your hospital and wants to do a bypass surgery or wants to do a kidney transplant or want to do whatever, you know, total knee replacement, that costs are quite high. And to maintain that cost, you know, we have to be sustainable. How do you think we can make it accessible to all? And I want to ask this first to Dr. Ankit, that how do you think these hospitals like Jupiter Hospital, if you want to make it accessible and high quality at the same time and affordable, what are the things you think we should tweak, the government should change or you should change so that people can have it at your hospital, the high quality at an affordable rate?
So I think I would just want to build upon what was said earlier. Dr. Reddy, gave a wonderful example of Indian Railways. Dr. Grant spoke about differential qualities and the cost structures, etc. I think when you think about accessibility and affordability, I think the key thing that we need to do is set expectations right. Not just in India, but nowhere in the world is healthcare affordable by anyone out of pocket. So it is a wrong expectation to have if we say that, and by no stretch of imagination are we the richest country in the world. So it is a wrong expectation to have for a common man to be able to afford a hospitalization expense out of pocket. The only way to make it happen is through managed care through insurance systems or through either government provided, employer provided, or personally acquired insurance. I think you'll have to think of it that way in order to think about affordability. And already today, insurance in India is very, very affordable. So I think that is the right way to think about it.
So do you think there is a role, and any one of you three can answer, Dr. Sangeeta or Dr. Parvez or you, that if the capital cost, let's say we want to put a PET scan, or we want to put an MRI machine, or you want to put a high-end robot, or recently you put such a lovely machine for a scan of the heart, and these things cost money, and these are all not made in India. Is there any way where these things can be made in India? The cost itself, the capital cost can be reduced so that the end user, that is our patient, pays less bills. Dr. Sangeeta.
So clearly Make in India, reducing the cost of the equipment, which adds to the cost per bed, is one of the levers. But it's not the only one. I just wanted to make one additional point on the earlier comment. I agree with everything said, is that first we have to face the fact that we are not expensive. We are 1/10 of global prices. We must not be apologetic about our pricing. That is one of the problems and then we hear people saying you're expensive, then we try and cut corners, therefore you cut quality, therefore you're not sustainable, then you sell out to PEs. We're creating a negative downward cycle. So we must ensure, and then like he rightly said, universal health insurance coverage, high quality standards, differentiation of the various strata of healthcare, preventive healthcare, and reducing input cost. It's not a single answer. It's all 5, 6 working together.
Yeah, I think multiple factors. Yes, Dr. Aditi.
Yeah, on one side, government is asking that Ayushman Bharat is a great scheme to implement in the hospitals, but we do know that when we create a hospital, input cost itself per bed is around 1.5 to 2 CR. In this scenario, even the patient nowadays is seeing all the private hospitals with the lens of commercialization. They are thinking that all the private hospitals are there to charge more money. The doctors are there to charge more number of tests. So in all these different scenarios, you as a healthcare builders, what you did, how do you try to balance the commercial angle, the running of the hospital, and the expectation of the patient when it comes to the cost and the quality of care? All three of you.
Yes, we'll start with Dr. Parvez.
See, the basic, what is really happening now, let us look at the scenario in Pune. What percentage of patients coming to my hospital are insured? I mean, that is something very important. I think it's only about 30 to 32% of patients coming are insured. The remaining have to pay cash or put the money down. Then we have some government organizations which we are associated with, which contributes about 20 to 22%, 23%. And even that, the problem with the government, like police, like the army, like CGHS, like central government, payments don't come on time. And that is another huge problem hospitals are facing. We ourselves are owed more than 100 crores by various government organizations. And how do you have a debt of 100 crores, money not coming, and you have to keep paying salaries, you have to keep running your show? So what is happening is slowly, most hospitals are trying to go in the insurance sector. Most hospitals are going slowly down in the government sector because we don't want to take too much of that because there's too much of a burden on us. So this is what the trend is, basically what is happening on the scene. What happens in Pune happens in Delhi, Calcutta, and most of the other cities as well. And this is the trend that we are seeing more and more and more. So we need to go more private, less government, less this type of thing. We do a lot of social work also because we are a charitable trust compared to other hospitals which are not charitable trusts, but they are corporate entities. So they don't have to do the same amount of charity work that we have to do, unfortunately. So that also triggers a lot of problems for us. That also triggers a lot of problems for us because we spend about 30 to 40 crores on free treatment And that again has to be coming out of the same pocket. Corporate hospitals do some amount of charity. I don't know what percentage they do. But we are forced to do this charity, and we are controlled by the charity commissioner. And the charity commissioner, especially in Maharashtra, is very active. They want to make sure that the work that we do is completely channeled. They come and check us out every few months. There's all sorts of audit that goes on.
Yeah. So anything on the same question, what she asked, between that trust deficit somehow where people feel that, the patients feel that doctors are sometimes over-investigating, and where, the patients feel like, oh my God, suppose, to put this into perspective, a patient comes to me and I advise him a arthritis profile, I advise him a osteoporosis profile, it costs 10, 12,000, all the tests come normal, and then they feel, oh God, everything is normal, why do they do that? And then sometimes patients get a test done somewhere and they find out that their ANA test is positive or vitamin D is low or whatever, and then they come and say, oh, this doctor missed the diagnosis. So we are always in a dilemma between over-investigation and, missing out something. So how do you tackle this? What do you think of this trust deficit which develops, Dr. Sangeeta? How can we tackle this issue?
I want an assurance from all of you that there are no media in the room.
No media, and this is...
Okay.
Please stop the recording for 5 minutes.
Okay. So let's be very, very honest with each other that there are things which are happening in the healthcare sector which all of us are not completely proud of. Whether it's, who some are doing, some are not doing, whatever it is. So I think we need to recognize the fact that the trust deficit is growing out of 2 or 3 things. One is inappropriate behavior. 2 is communication by those who are doing or not doing about pointing fingers at the other, and therefore maligning not just the other hospital, but maligning the industry at large. So I think it's very, very important for us. Number 1, don't compromise on your quality of care. Number 2, please communicate with your patient as much as you can. Over-communicate, let them understand what they're coming into. Number 3, don't be apologetic for asking for the right reimbursement, yet don't be opportunistic in scenarios. I know people who during COVID charged 4 times the price. That was, it spoiled our reputations. And those who did not, it's built goodwill for us for years and years. So it's a combination. I'm sorry I'm giving you a long rather than a short answer.
No, this is what we want.
But the fact is, the truth of the matter is, we must put our foot down on inappropriate behavior. We must connect with the patient much better. And to be really honest, we have to control our own teams, our investors, if we have external investors, and our doctors, and ensure that they stay within guidelines. We all know what's right behavior. Let's enforce it.
But ma'am, with the kind of medical legal issues which are coming up day by day, doctors are, they want to defend themselves. That is what defensive medicine, the term which we are nowadays listening. That is one of the reasons why doctors are prescribing more number of tests. So in this scenario, that is one of the reasons, because they want to protect themselves in the hospital. So in this scenario, what should be the way out where the private sector, all of us, and some suggestion to the government how we can protect our doctors so that they are well assured that we will not be there in the court addressing some issues raised by some patient.
So once Dr. Sangeeta answers, maybe Dr. Mahesh, you can also, you want to say something first and then Dr. Baldawa can answer.
So my very simple thing is that you cannot have vested interest in the prescribing of diagnostics. Point number 1. You cannot, have a financial agreement. So the only reason you prescribe a test should be because of its clinical efficacy. And today, because of standard operating protocols and AI, it's very easy to test. I'm not saying underdiagnose or under-refer. I actually feel sometimes it's better to do more because you don't know what's underlying. And missing one brain tumor because you saved 5,000 rupees from a patient for his CT scan, for his life, that family is going to curse you. So it's much better to order the test, but order it based on clinical protocol. That's my only
So
simple
Dr. Mahesh, he'll be speaking later, but he's a pediatrician and a medical legal expert from Mumbai. You have any thoughts on this?
Yeah, good evening, everyone. See, there are two aspects to what she said. It's very philanthropic, and it should be done. But then, legally, it is something different. So there is a cost to everything. And as Dr. Grant said, it's a different tier cities, different kind of equipment, and different kind of the ticketing size, which is important. So I did not join them in the previous discussion, but I'll just say that I went to city of Kota, which is in Rajasthan. Kota is a big city, and a lot of big hospitals are there. And they have a sister hospital, There is a Devli, 50 or 100 kilometers away. So those who cannot afford, they try to refer them there, Exactly. The same, everything is same. Only thing, the person is transported in their vehicle to that place. Okay? And everything, all the doctors will go there, treat them. As he said very correctly, in Pune, the land cost is more, the maintenance is more, the infrastructure cost, whatever payments you make, everything is more. In Devli, there are less restrictions. Even the people who accompany them, they are given accommodation there. And they can cook their food there, they can feed their own patient also, and hospital food is also available. So that is just
the question
previous one. Now I'm coming to the main question.
But just to that very quickly, what question arises out of this, Dr. Mahesh? Will they get the same kind of quality care which they get in Kota versus the way go
No,
to
I'm
Delhi?
coming to that.
So that is, I think, if that can happen, then of course, we can cut on the overheads, we can cut on the frills and keep it as, like a low-cost
Let's come to the cost
airline.
of the investigation.
Yeah.
So there are two aspects. If the investigation is advised, it must be advised. And if the patient is not able to do, you should take a negative consent. That, okay, we cannot afford it. I do not want to give blood transfusion. I am a Jehovah's whatever kind of a thing. Or we do not believe in this kind of, I am an anti-vaxxer. I don't take it. Take it in writing. That is very important from the point of view of medical legal. Now, if you really want to do it, and the basic, why it comes in our mind. See, in our country, the Consumer Protection Act says that the entire thing should be over within 90 days. But it never ends in 90 days, not even 3 years, not 6 years. Unfortunately, some of my own cases are going on for 18 years.
Bapre.
Okay? So, and then there are appeals, first appeal, revision, various kinds of things, till you reach to the Supreme Court.
So to the point of the consent you are talking, that you take a consent in the outpatients that, okay, you are agreeing to not the complete area of investigation and we make him sign there and then?
Yes. And the consent has to be very tactical. It cannot be the way we are thinking as doctors, that okay, in OPD, suppose as a pediatrician, I need to admit a patient with a dehydration. So we tell that they want to think and consult their adult members or other members, and they'll come back to us. This is the kind of consent.
Yeah, so before Dr. Sangeeta, I know she wants to make a comment, but if you make the patient sign such a consent, I don't know how much, whether he will really think if he has to undergo a surgery with you, will he come back or will he really go to another person and think? So that's one point you have to keep in mind. But I agree with your suggestion. Dr. Sangeeta, you were saying something on this point.
I wanted to make one quick point, which is that data capture. Your recommendations are critical. Whether you go up to the point of saying, the consent, he did it, not consent. But if you have a correct OPD form where they've written all the recommendations to do, then I think, and you have a copy of it, because sometimes we have inpatient, but we don't have outpatient. So if you have a copy of it, you are number one protected to some degree. But the problem which is happening now is that they're writing X amount in your file and writing the CT scan referral in the neighboring diagnostic paper. And there, you will long term, this practice will come back to hit us because this paper will be missing from your record. So I would want to practically warn everybody today, please tell your doctors that even if they're sending somebody outside, let them say they're going outside because the price is cheaper, whatever they want to say. But make a note in your own record, because otherwise the cost of that will be far greater in the future.
I think that's a different, we are digressing, but that's an important point. Sometimes the investigations do go outside a particular corporate hospital or private hospital, but then that should be documented. There's no problem to send it. I get I definitely get the point.
Let me finish it.
Okay, please, sorry, sir.
What happens, the litigation goes on for a long time. And that's the reason there is a negative feedback amongst doctors. Kind of a fear, kind of a wrong kind of anticipation that if I don't investigate, or if I do not tell, or if I do not write, so there is a overreaction on the part of doctors to protect himself in the name of investigation, in the name of surgery, or not doing, or doing, whatever it may be. So they want to play with words, they want to take negative consent, they want to also advise surgeries, more surgeries, less surgeries, whatever kind. There are situations where they would like the person, if it is not, like for example, the head injury. The neurosurgeons, he knows the outcome. He might tell this is inoperable. This is a kind of, and no one will come to know this defensive medicine. See, this is the worst kind of thing.
Yeah. Something, AI, Apollo is one of the pioneer hospitals which worked on creating AI platforms. So, and there are few hospitals who are working aggressively in that particular sector, but many hospitals are still waiting to catch that train. So can Apollo hospitals and few hospitals like you can create a platform where the hospitals, newer hospitals, or the hospitals who cannot invest in AI the way your hospitals are, to get that guidance, how to use AI in the complete hospital execution, if we can have something like that?
So absolutely, Aditi. I think we're already sharing some of these. It's an algorithm. So you just pay per what you call API call. Every time you pull once, you use it in your environment. It's absolutely possible, and very happy to have our team do maybe a larger thing. Also in January, we have a large conference in Goa, which is Transforming Healthcare with IT and Patient Safety, where we'll be talking, one's track is only IT and AI. So everybody is welcome. I'll make sure I send the invitation to everyone.
Great. Thank you.
Yeah, I think just going ahead with this AI, I think I want to ask Dr. Ankit, what do you see the future of AI? I think AI is here to stay. I don't think anybody in the room is going to deny that. Like, 20 years ago, when you talk about the smartphones, at that time you were contemplating, but today everybody has smartphones. And I think that is what is going to happen about AI. We have to make it a part of our life. So what is it that you're doing at the Jupiter hospitals? Are you integrating your protocols with AI? How are you adapting to the new technologies? Is there a resistance from your consultants on using AI? Or what is the policy of the hospital on AI? Can you enlighten us a bit on this?
Yeah, I think it's no discussion or conference is complete today without an AI discussion. And of course, the doctors share their excitement and enthusiasm. Having said that, I think it is still a nascent technology. It is definitely going to evolve and evolve very, very sharply. But as we speak today, there are a lot of new initiatives which are being done by various people on the clinical front, but not mainstream application on the large scale yet. On the back of the house business processes, of course, it's a different story. There is a lot that can be done today also. We are doing some of that. But on the clinical front, I think, because there are doctors also in the room, I think AI is something which everybody is excited about and wants, but what we need to understand is what is the price that you have to pay for AI. I think the price that you have to pay for AI is to drop your pen, right? If you don't have digital data, if you don't have digital records, and if there is no systematic data structure and database and backend integrations, then it is impossible for the AI to do anything with it. So as clinicians, the comfort of the pen will have to be given up if if there is a serious ambition on AI, and I think we are doing some work on that, but I think that is for everyone to participate in.
Yeah, so
I think AI will, first of all, the radiology department will be affected the most in the next 2-3 years. What you will find that you have an X-ray. Immediately the X-ray is put into the AI and you get your report. You have an MRI, you get a report. You have a CT scan, you get a report. You have echo, you get a report. You have ultrasound, you get a report. So slowly, slowly what is going to happen, and this is going to happen 101%, you will find that radiologists will be slowly replaced by AI. Of course, they will have to sign the final report, but instead of 100 radiologists, you need only 5 then.
yeah,
This is
I
going to
think
be
that's
the
what is going to
future.
happen.
In
And
the next 5 years, this is going to definitely 100% happen. And that's where AI is going to go.
I think we have to plan for that. In the same, please, we are going to open this up for an open discussion to all the delegates who reserve your questions and think about them. In another few minutes, we will open up the whole discussion to all of you. Dr. Parvez, I have a question, just slightly shifting gears and moving on to a little bit of economics of healthcare in Maharashtra, especially if you see a city like Satara has 11 MRI, a city like Ahmednagar district has totally 18 MRIs. Pune itself, we have 95 MRI scanners, 11 PET scans, more than 24 cath labs. So much of infrastructure. And if you compare this to, let's say, a London city, the London has all put together 15 or 16 MRIs to the best of my knowledge. So how does this work? And you yourself had put up so many MRIs in Maharashtra, Dr. Parvez. Can you educate us on how this works and what is the maths you do and what is the calculation, Dr. Parvez?
This is a very, very, very interesting topic that you have brought out today. Whole of London has got about 16 or 18 MRIs.
That's it.
And yeah, and they manage the whole city, maybe 20. A small town like Satara, which is 100 kilometers from here, has got 11 MRIs, all fighting with one another, trying to get the same business. Now, it's not easy to run an MRI. I will just tell you the story about what happened in Fulton recently. A small group of doctors got together, hum MRI banayenge or MRI chalayenge. These people, without thinking, went and bought a 3 Tesla MRI. I had a 1.5 Tesla MRI in Fulton. And there was another doctor who had a 0.5 MRI. So there were now 3 MRIs. I said, 3 Tesla in a small village like Fulton, how the hell is it ever going to run? Now, let's work out the economics. Electricity bill, 5.5 lakhs a month. Interest on the machine, 5 lakhs a month. That is 10 lakhs are already gone. Salary is another 2 lakhs. The company charges another 5 lakhs a month for your CMC.
The rent and all that.
So before you know what has happened, you're spending 17 lakhs a month without doing a single case. It's like a engine running which you have to keep on popping to keep it running. So when they put the 3 Tesla, I simply laughed. I said, fantastic. Exactly what I predicted. In 2.5 years, they all came to me, Saab, humko bachao. I said, kya ho gaya? Sir, we can't run the machine. I said, close it down. Exactly this is what has happened, and this is what's going to happen to these rural MRIs that people, all small doctors put in the hard-earned money. Out of the 11 machines in Satara, in the next 2 years, you will find only 6 or 7 running. The remaining are not going to be economically viable. So you have to be very, very careful. I mean, doctors love to invest. They love to start their own little things. Great, fantastic. But remember, there's a cost. And in the end, you're going to lose a lot of money.
Yeah.
And this is exactly the example which I have given. Be very careful where you go into.
Absolutely.
Especially the smaller cities. They don't have the buying power.
Yeah.
A similar state is going to happen in Pune as well. There are now 4,000 hospital beds planned in Pune in the next 3 years. it is going to be very, very difficult for these hospital beds to be filled.
But you think Pune doesn't require 4,000 beds?
Pune does not have the capacity of filling 4,000 hospital beds in the next 3 years.
With all the periphery draining into Pune? Difficult?
Well, I don't know. Personally, I don't think they'll be able to fill so many beds so suddenly. What has happened suddenly, everybody in the whole of India has woke up, "Arey, chalo, hum Pune jayenge."
Hyderabad jao.
"Arey, aao, hamare saath aao." But
yeah. Parvez, just to move on from this, and the cue I'm getting from the answer you gave, and this question is to Dr. Sangeeta. We are talking about, 2-3 people coming in and putting an MRI and what Dr. Parvez said, just to take that forward. Now, many people have these 5-bedded and 10-bedded hospitals. Do you think these hospitals are going to have a future, or they're going to be like only place for 50-bedded where 10 people come together and become directors and start a 50-bedded or a 100-bedded hospital? Do you think the 5-bedded and the 10-bedded nursing homes in rural areas are going to finish over a period of time? What are your thoughts on this? And do you think you should actually preemptively try and collate these 10-15-bedded hospitals together and give them a better infrastructure with bigger facilities? What are your thoughts on this?
So I think that there is a tremendous future for the smaller format tier 2, tier 3 hospitals. I don't think it's 5-10 beds. The economically viable number is probably 50 to 75. And there needs to be some good framework on what they do and where they'll refer. If they're part of a larger referral ecosystem, they'll have a better future. But the needs of India have to be looked at very differently. And therefore, I think the 5 beds doesn't make sense unless they're converted into urgent care, daycare, that kind of formats. So the generalized nursing home of 5 beds is gone. The future is specialty formats, medium-sized hospitals, but tiered into lower end as well has a very good future play.
Yeah, absolutely agree, Dr. Aditi.
Yeah, this is a different question. Both the medical legal consultants, experts are there. Nowadays, we are seeing a lot of assaults on the doctors. Some or the other doctor has faced once in a lifetime assault from the mob or the patient relatives. So, Mr. Baldava, in such situations, how do we protect our doctors? I was supposed to ask this doctor to our minister also, what government is doing, because there are different laws available per state, but there is no uniform level, law which is at the central level, which is protecting. And laws are there, but those are not getting enforced so that we can protect our doctors. And it is very important for doctors to treat freely without having that pressure on the mind. So what we should do as a hospital and the doctors to protect ourselves from these kind of incidences?
There are 3 aspects to it. The organizational level, the small hospital, and the individual doctor. Most of the time, the trouble will brew with individual doctor or nurse. So the flying brick of violence or mob violence, no law can protect, nor the doctor's stethoscope or his degrees. So you need to keep some self-protection equipment for a person, at a personal level I am telling. So you need to have under the desk pepper spray, or in your pocket pepper spray. Or now toy kind of 900 gram revolvers are available, which do not require any license. So it's good for, keep the person at distance. Always make sure in your individual consulting room, there's a rear exit. Because at that time, you cannot venture going out of the front exit. So this is for the individual. Now let us see at the small level hospitals, small 15 bed, 20 bed, 50 bed, like that, where there is nothing organized kind of a security. Some guards are there. You don't have metal detectors. You don't have X-ray machines. You don't have alarm systems. So at that kind of a system, so you should have some SOPs, some protocols, that how a call is given, so everyone gathers at the same place. Something kind of, when you give for your, some person is dead or some person needs resuscitation. Then Top level is, of course, corporate hospitals, big hospitals, charitable hospitals. There, you have to have a security department. The guards don't protect. You may have number of guards, but they are underpaid. They are servants. They are the first people to run away. So I don't think it's a false kind of a security. Nor will have the will insurance protect. Police will come at its own sweet time. But you do have to call the police. All three people have to call the police. Post-event, maybe.
Yeah.
Insurance also will work. CCTV camera will also work post-event.
Yeah.
So all these things, you have to have your personal protection intact, or you should have the weakest person also joining you together while the violence is occurring.
Right.
Thank you.
So you have to take everyone together.
Yeah. No, I would like to ask Dr. Ankit, Dr. Sangeeta, and Dr. Grant, what we should do to talk to the government to enforce these laws so that we can protect our doctors.
Yeah, something at a policy level, because what happens at that moment of time is that event is done. You know, like for example, all of us are fresh with the memories of what happened in Thane. You know, our own doctors getting beaten up ruthlessly. I think that's something, but that is happening. What can we do then is one thing, but probably sir has given some good ideas.
We are fortunate, someone has taken cognizance of it.
Yes.
And the bail is cancelled.
Yes, but now how do we teach such people a lesson that they never do it again? Yeah. So that is what ma'am is asking. We want to start very quickly, quick answers, because then we want to open it up to the delegates after this, and we have 2 more talks by our medical legal experts.
So sir is already a medical legal expert. I don't want to go down on that route or his territory. But one interesting study comes to mind, and maybe, I mean, we can first start by saying that the incident you are referring to is just terrible and the lowest probably level that humanity can go to. It's must be condemned. Having said that, we can of course ask for help from government, security systems, ABC, but what I think is it's always a good idea to think about what you can do, right? And on that count, there was one interesting study which I had read many years back, which I quickly wanted to share. America being one of the most, or probably the most litigious healthcare system in the world, there was a large study over several hundred patients who took their doctors to court. Of course, did not really hit, but took their doctors to court. Multifactorial study, trying to determine who gets sued and who does not. And very interestingly, the variable which had the highest statistical significance, what was the difference between the guys who did not get sued versus those who did? On an average, the doctors who did not get sued spent 4 minutes extra talking to a patient than those who got sued.
Really? So, yeah, that's a great message. That's a great message.
So communication is absolutely the key.
Yeah, so those are the situations where, of course, you do go that extra mile, spend 4 or 5 minutes more, but in a situation where, there are the mob violence, even if you do a code violence.
What incites violence, essentially, is the last straw on the camel's back. And very often the media, the narrative, a lot of it just stops analysis at that last straw. But as is the case, the last straw is not really the whole story. There are too many other things. And if not all, but I think strongly believe that a lot of these things can be curtailed with better communication, better consent, better,
Absolutely, Ankit. One short comment by Dr. Sangeeta, and then we open it up. So anything about this?
I think we all have to collectively push governments to ensure that there is immediate, quick, punitive action against people who have done that. That is 100%. Second is isolate the difficult zones. Emergency rooms and ICUs are the critical ones. Hyper focus on those areas. And the third is control mob or large number of entries proactively from the beginning. These are 3 simple steps. I don't think we've perfectly done all, but we're working towards it. This open thing where hundreds of people walk in and hundreds of people walk out, that itself is a risk in our large hospitals. We need to begin by starting a pass system, a movement system, and specifically control emergency and ICU. these are your trouble spots.
Yeah, so with these comments, we'll open it up. Any quick questions? And then we have two very interesting talks, one by Dr. Shanoy and one by Dr. Baldawa. Any one or two questions? Anybody, please hand on the microphone. Yeah, please go ask. Hand the microphones. Just one or two people can move around with the microphones. Yes, ma'am.
Yes, good evening. I'm Dr. Ruchira Khanna. I'm a dentist. I'm a prosthodontist. So when
Put on the lights.
Yeah, I'm sorry.
Let the delegates also come to light.
So when we were speaking about insurance, the entire world, especially the Western world, has dental insurance. I have come across so many people in the last 2 decades of my career where they have debilitating dental disease, which affects their general health also, and which has been put into the back burner. There is no dental insurance in India. What are you as healthcare providers, as hospital leaders doing for this?
So your specific questions about dental health
Dental
care?
insurance.
Dental insurance. Yeah, I'll let the panel answer, but unfortunately dental healthcare comes under cosmetic. So, that is why most of these insurance companies I have seen, and we just had a very big, conclave with the insurance companies, all the hospital owners were there. And this issue about, pediatric or neonatal problems of babies who are born with deformities, they are also not covered under insurance, and dental also is not covered. But I would be happy to let Dr. Parvez, Dr. Mahesh.
Yes.
No, put on the mic, please. Dr. Mahesh's mic.
Hello.
Yeah.
Abroad, if you pay
Higher premium.
general insurance cover whatever the government gives free. Abroad, it does not cover the dental. But if you go for a higher bracket, then in each category, root canal, maybe cleaning, maybe caps, maybe your orthodontics, etc., is covered. You said very correctly, this appears cosmetic. But in India, also, we are trying, at least I am trying to pursue the insurance. It's a very profitable thing as it is abroad. So they might introduce with the IRDA insurance thinking with a higher kind of a premium for dental. Regarding the cosmetic part, I think it will never be covered.
No, I think very quickly, let's understand that insurance in our country is quite a young stage. Outpatient is only now being covered, and I think Pune is among the early ones with Bajaj talking about OP insurance. Dental will come as a next step. And the day we're able to automate better, have clean claims and less fraudulent claims, the easier it will be to cover these kind of things. And I think corporate will take the lead. It's not too far away. Wait, next 3 to 5 years, you'll have it covered.
Yeah, but coming to the other problem, suppose now, suppose you're insured, you have a child. The child has got a hole in the heart and born with a hole in the heart. It goes for cardiac surgery. Now the child is not covered in the insurance policy.
Yeah.
You are covered, but the child is not covered. So this is another area where you need to seriously look at that.
There is coverage for...
In the last meeting, Dr. Parvez, we had a big discussion on this, on
now
congenital
there is a
anomalies,
policy which covers.
and now they are going to
How do you
cover
know
it
your
under the
child is
parents.
going to have a hole in the heart unless you've done an ultrasound before
we'll
delivery?
just take 2 more questions. Yeah, one there, ma'am.
Thank you. Hi, sir. I'm Dr. Kauravi Zade. I'm an interventional radiologist.
Okay.
So my question to the panel is, as a doctor, we are dealing with emergencies day in, day now out. Do we have right to say no for some surgery where, for example, if I am doing one patient, it's not about cost. It's about the political pressure, the mob standing outside. And like we know, the chances of patient dying on table is 60%, right? And there is a huge mob standing outside. And you know, you can do your best, but because of the mob, sometimes your confidence may go low. So do you have the right to say no for a life-saving surgery?
Yeah. So just to put a question to perspective, it is a high-risk case. You have to do that procedure. It's a do or die. But there are people outside. Let's say it's a ma'am is gone, so it's a politician's relative, and the whole constituency is standing outside. So,
Yeah,
so do you have the right to say no, Dr. Baldawa? Can we refuse this patient?
Logically, if you go to say, on the paper, you have a right to say no.
Really?
If you say no, then your bones will be broken, your skin will be blue. property will be damaged at
Paper
your
spray.
risk and responsibility. So you say no. See, law is different. Law is post facto. Things are over, then law will come and protect you and punish the people who are miscreant. If you want to be intelligent and be proactive, you want to preempt, then you have to use your own kind of intelligence, that you do something, telling them this is high risk, this is what I am going to do, but finally the patient is going to be dead. But because you people are telling, I am doing it.
Proper consent.
Your proper consent should be, high risk consent should be there, high risk anesthesia consent should be there. And according to me, 2 or 3 big representatives of them should be in the operation theatre, witnessing it. There's no problem.
So normally we are taking audiovisual counseling also in this kind of thing, but still many a times
So I
like
think
we are
there
doing
is
this in midnight and
the answer to your question, ma'am, if I am in that situation, I think there is no way but you cannot refuse the patient, because if you refuse and the patient dies, then it's a worse risk.
Worse situation,
because it's a high risk case anyway. So what has been said, proper consent, counseling, video consent, sit with them. What he's saying, 4 minutes instead of 4 minutes, spend 14 minutes on counseling them, taking consents, and then you go ahead and do it. Because the risk of not doing it is probably higher than doing it and the patient dying. So that would be the answer.
Dr. Parag, I was in
while
Jaipur.
you're doing the surgery, call the police to be there.
While you're doing the surgery, call the police. That's a good answer.
Dr. Parag, I was in Jaipur, and there was a situation like that, neurosurgeon.
Okay.
The entire thing was smashed with the rear truck tire.
Right.
And nothing operative. But the crowd expected doctor should do some miracle.
Yeah.
According to the doctor, the patient was already dead.
Exactly.
So he had to take the dead patient, and like a postmortem person, whatever they did, he repaired he sutured. He took it sweet 4 or 5 hours. He
Right.
told that I did a great thing.
Yeah.
But now
Exactly,
future,
sir. This is what happens when a patient is actually brought dead to your hospital, and then you are just doing CPR and then trying to revive the patient. Feels no. When the patient came, he was alive. So you killed the patient. So I think it's not the right platform, but when a patient is brought dead, should we at all try to do a CPR or try to revive him? Because if you try and then the patient's relatives feel, no, he was awake, he was, there was some kind of activity, he was gasping, and now he has died under your guidance. So that is a real difficult question. So my answer to that, what we've decided at Sancheti Hospital is, if the patient is brought dead, we do not try anything. Declare then and then that he is brought dead. Otherwise, the onus is on you. Yeah. I think
Dr.
we'll take
Meenakshi
one question from
Deshpande.
I hope some...
So, 1 minute. I will just continue on with the topic which we are going with the mob violence. Because when we are having so much nice leadership from Pune, also from Maharashtra, why don't we press for a central act of protecting the violence against doctors? We should press for a central act in which we should give a non-bailable offense. We should make violence a non-bailable offense. And we have got Anupriya madam coming over here and asking for our opinions and our suggestions. I think it is our right to ask for a central act. I am Dr. Meenakshi Deshpande. I was a past president of IMA Pune, and I'm also into the medico-legal field. But still, we are not successful in getting the central act passed. And they are now bringing in the new Clinical Establishment Act, in which there are absolutely no sentences regarding security of the frontline workers, security of the doctors. We should press for that. That will be my opinion.
Absolutely, ma'am.
Ma'am, I agree with you, but just one line. Health is also a state subject.
Yeah.
In Telangana, actually Andhra combined, we got it passed at a state level. Please do your state level first. It will strengthen the momentum for the national.
Yeah.
Your
So
points are very good.
I think we should
but
go in
you
for
should
state level, and
go
our
state level.
leaders in Maharashtra also should press for that.
Yeah. So we'll take one last question, just because this program, the chairperson is Aditi madam, and the chief guest was Anupriya. Only females are asking questions. So I hope, let's give a chance to the male now. Yeah, last question. Apna bhi awaaz aana chahiye, bhai.
Thank you so much, sir. So, I'm Dr. Ankit Khanna, and I'm founder of Vita Den Care, and it's the only company in the world, I would say, which specializes only in oral health care inside hospitals. So we were the pioneers of starting dental clinics in India. We were the first chain. In COVID, we stopped all our centers and we started going to hospitals that let us run your dental units. Why? Because people were dying in COVID, majorly because of inflammatory response of the body. And that can be very well taken care of if they were taking care of their oral hygiene regularly. We started promoting oral health care everywhere. Now, if I say that I can identify a person is going to develop diabetes just by looking at the oral cavity, nobody will believe me. But inside the hospital, if I say that, there are doctors who will back my saying. So I would like to know, why is oral health care not coming into mainstream healthcare system? It is just a part of health packages checkup. I would like to bring it to the mainstream healthcare, because if senior citizens, all of us have some or the other kind of medical ailment, blood pressure, diabetes. If I need a third molar extraction, if I need an implant, a hospital is the best place to get my surgery done, not a private clinic. So I would like to bring this into the light.
No, totally agree with you, Dr. Ankit. I think during the next Medharmony, this should be the theme. We will take it up. That's an important point. Thank you for this comment. I think with this, we'll end the... Sima, one last quick question.
Sorry, thanks for it. I'll just take that forward. It's actually the onus lies on the dental community. It can't be put onto the others. Let me give it to you this way. Sleep apnea, according to science in the country, is a lifestyle disorder. We, at the association, we did this, we did a study, we proved this, that sleep apnea causes all these problems. So before you put the onus onto the other people, I think the dental community needs to prove this in literature. And then you can probably appeal to them.
So next year, both of you will be speakers. No, let's rest it here. Okay, don't worry. So thank you very much, the panel. A big round of applause for Dr. Sangeeta, Dr. Parvez, Dr. Ankit, Dr. Baldava, and Dr. Shanoy. Just hold on, it's going to be 20-25 minutes more, and then there's a sumptuous dinner waiting for you with some cocktails before that. We will now hand it over, and there are two very interesting talks, so please don't leave the hall. Yes. The doors are closed outside, by the way.
Thank you, all the panelists. Can we have a big round of applause for everyone? Because of time constraint, I know you have many questions, and we'll try to answer them. Thank you, everyone. Please move. I request all the dignitaries to please move on the center table. Our next two sessions are more important than ever, especially in today's era, as they are about medical issues faced by doctors in MBBS and residency. We learn what to do, but in the next two sessions, the next sessions will tell us what we should not do. Before we move on to the next session, I would like to play the video of summary of inaugural Medharmony 2025.
In a landmark moment for Bharat's healthcare ecosystem, over 500 distinguished doctors representing more than 50 specialties came together under one roof. For the first time in Bharat, healthcare leaders convened not just to discuss, but to reimagine the future.
Through our collaborative efforts, let us commit to embracing innovations, advocating for equity, and nurturing the cooperation. Together, we can create a healthcare system that addresses the needs of today while preparing for the challenges of tomorrow.
Medharmony unfolded as a transformative confluence, where the future of healthcare met the force of collaboration. This vision was brought to life by a distinguished organizing committee, the minds that made it possible.
We think about it as patient first. We think about it as all of us, be it a chairman, be it a security person, be it a HK person, is there for one reason and one reason alone. And that is focus completely and entirely on the patient and their family. Equally important, their family, because quite often the family is more traumatized than the patient. So that is what we focus on.
I would say that future of prostate surgery is urethra preserving as a urethra surgeon. So in one subspecialty of urology, so many advances have taken place, and this happens in everyone, like ophthalmology, orthopedics, gastroenterology, and I cannot enumerate all of them, so I have taken liberty to tell you something about urology.
Any doctor, whichever specialty, whichever part of the country are practicing it, whatever your status of practice, you have to know artificial intelligence. It's going to become a part of future of medicine.
Young generation are AI savvy. So with thesis in our institute, radiology, 50% of the thesis are AI related now, and subjects like dermatology, ophthalmology, where AI research is going to make big leaps. 25% of our research and our postgraduate students.
Thought leaders, pioneers, and change makers shared bold ideas and breakthrough insights.
Basically to express our issues related to insurance, the issues related to legal problems, ethical issues, and so many other issues keep cropping up in the practice. And we need a strong platform to not only voice them, but find innovative solutions.
We got the guests who are unwell. The bigger the hospital, bigger is the need of human touch, my friends. Very important. The more higher you become, the more hospitals you have. That's why I always say the hospital should be big enough to serve, small enough to listen.
I didn't do in the 100 kilogram body, I focused on 15 gram gland, that's thyroid. So much so I focused, I'm the first man in the entire world who has built a brand around a gland. So that's about thyroid.
Medharmony delved into pressing themes, reshaping the healthcare landscape.
Pune, which has now more than 18 multi-speciality hospitals with more than 500 beds and a total bed strength of more than 28,000 in Pune, I think Pune is definitely set to become the healthcare destination for one and all.
I think there should be more daycare centers. We should have more daycare centers. We should have more telemedicine because that reduces the cost. The person doesn't need to come home to come to the hospital. He can do it through telemedicine. So these are the areas where I feel that we should definitely look at the insurance sector even more and more.
But beyond the sessions, it was the exchange of ideas, the forging of new partnerships, and the shared belief in a better tomorrow that defined the experience. Medharmony became more than an event. It became a celebration of those who heal, those who innovate, and those who lead with heart.
The 77 years, what we have achieved is great, but I think our demographic dividend, how to channelize their overall thought process is a big challenge. And as a education system and as a capacity builders in the country, and education is such an important thing, what I feel.
Medharmony, where science met soul, and a new chapter in healthcare began.
Dr. P.D. Shenoy for the next session. His topic is balancing clinical judgment, ethical decision-making, and legal accountability. May I invite Dr. Parag Sancheti and Dr. Ankit Thakkar to felicitate Dr. P.D. Shenoy. Dr. Ankit Thakkar. Dr. P.D. Shenoy, former Secretary, Government of India, and ex-member NCDRC, medico-legal expert. Dr. Shenoy holds the rare distinction of dual credentials in both medicine and law, establishing him as one of India's foremost authorities on medico-legal affairs. Please give a big round of applause for Dr. P.D. Shenoy. I request Dr. P.D. Shenoy to address the gathering.
Shall I start? Yes. Okay. Vaidyo Narayano Harihi. Marathi Abhanga, which is slightly modified for today's conference. Kote jansi manuja aata deva dunduna deva kute aahe deva aahe vaidya hradai preme bandona. Crores of devotees are coming in search of God. Where is He? He is in the hearts of doctors, the surgeons, and physicians. Now, the subject is Medharmony. And when we look into this subject, several thoughts come to us. Considering that today's there is a change in the atmosphere in running, in the practice of the doctors, in the practice of the lawyers. Now, if you look at, now the litigation is taking place against doctors also. When research was done in an European country, they found that the doctors who spend more time listen to the patients or their WhatsApp nicely and respectfully, they are less to be sued against. As against the doctors who show off that they are very busy and they want to rush away, then they are likely to be sued. They may succeed or not. थोड़ा गरम पानी देना, आधा गरम पानी देना. Defensive medicine versus ethical practice. Navigating medico-legal realities is not an abstract theme at all. For the Indian doctors, it's a daily scenario. It's a clinical tension in recent years. The Indian health system has seen a steady rise in multi-forum litigation against our doctors. who have taken a lot of pains for 5 years of medical course, and those who have done post-graduation in several specialities of medicine and surgery. Again, they find it how difficult to face the litigative atmosphere. And this litigation doesn't stop in civil courts or criminal courts. It also comes to in the appeal forum, in the consumer fora. I had the experience of having a member of the National Consumer Dispute Redressal Commission for 5 years. Earlier, litigation against doctors were far and few, but steadily there has been a rise, a phenomenal rise against the number of cases against the doctors, not just in Consumer Commission, but also in the civil and criminal fora, justice fora. They are more in number. They are in all districts also of the country. So defensive medicine in our context refers to clinical decisions made predominantly. Sorry for a minute. This defensive medicine in our context, to repeat, refers to clinical decisions made predominantly to reduce perceived legal and reputational risk rather than to advance patient care. That is where the dichotomy comes. It manifests as assurance behavior, ordering extra tests, seeking multiple referrals, keeping patients longer than necessary in the hospital. Yeah. In my own experience, once when I had gone for examination, then the medical examination, then I found there was a column that they sent to me a psychiatrist also. How do I feel when I went for a test, general medical test? They made me pass through various specialties, including psychiatrist. Whether I should ask questions to him or whether he should ask questions to me was a big dilemma for me. Because he being a doctor, I felt the old state prayer, Vaidyo Narayano Hari, what I quoted today also. But his questions were, I found to be pretty silly, but I could not and should not tell him that. I answered patiently. When he asked me, take 5 steps, I took 5 steps. When he asked me some questions, I patiently answered. Then I asked him, can I ask you some questions? No, sir. Okay, fine, sir. Thank you, he said. Now, coming to, apart from assurance behavior, that is, results in extra tests, extra expenditure for the patient. So then comes the avoidance behavior. Doctors and surgeons avoiding some
complex cases, high-risk cases, refusing them, and apart from that, avoiding certain procedures or specialties. Now, like for example, gynecology or obstetrics and such other cases, that is an avoidance behavior. Now, it is difficult to have a zero-risk patient. However, when we examine defensive medicine against ethical duties recognized by Indian courts as medical bodies, a fundamental conflict emerges. As it is well known by the medical fraternity, a doctor owes specific duties to their patient. What are they? To reiterate what you already know, duty of care, duty to obtain informed consent, duty to exercise reasonable skill and diligence, and the duty to act in the patient's best interest. Here, I analyzed the half a dozen big cases of consent. The consent has to be comprehensive, exhaustive. Otherwise, that may result in litigation. Now, coming to ethical duties. When we examine defensive medicine against the ethical duties recognized by the Indian courts and medical bodies, a fundamental conflict emerges. Now, coming to the other side of the coin. Recent high-profile judgments in India have shaped doctors' risk perception. The Supreme Court has, in certain cases, upheld substantial compensation awards, putting the medical negligence firmly in public view. And you know, Supreme Court is supreme, and Supreme Court is final. So, we cannot disrespect Supreme Court, otherwise you will be sued for contempt of court. So we have two ends of the same subject. At one stage, we have Jacob Matthew versus State of Punjab case, which have laid down safeguards against frivolous criminal prosecution of doctors, recognizing the need for a balanced approach to liability. The message from these cases, when read together, is not every adverse outcome must be a negligence of the doctor. So whether the doctor has acted with the reasonable skill and care in line with the accepted practice. You want to may speak into the mic? No, sir. Away from the mic? Yes, sir. Yes, sir. We have to close. Away? Time constraint. Away from the mic. Yes, okay. We have to close the session in 5 minutes. Okay. Time constraint. Now, global literature, some of these concerns are analyzed or mirrored by them, describing assurance as avoidance behaviors and noting that defensive medicine can paradoxically increase costs and reduce care quality without demonstrable
gains in legal safety. But Indian situation is distinct. We combine resource-constrained settings, wide variety of infrastructure, and an evolving legal landscape that straddles consumer protection notions and professional negligence standards. Important narratives about defensive medicine from other jurisdictions do not always align with our realities, and Indian policy debates now explore alternatives such as no-fault compensation schemes to reduce adversarial litigation while still providing redress to patients. For practicing clinicians in India, the practical question now is to navigate these realities without slipping into unethical defensive practice. First, to recantering and established ethical and legal duties is crucial.
Sir,
Indian
because of
courts
time
assess
constraints,
negligence by asking whether a
Shinoy, sir,
reasonably...
yes, because of time constraint, we have to move to the next speaker. Can you please conclude within 2 minutes, sir? Yeah, please conclude within 2 minutes. Sir. I request you to please conclude within 2 minutes.
Okay. Secondly, clarity about consent and communication can significantly reduce medico-legal risk. Third, institutions can help shift the culture away from fear-driven practice. Indian commentaries highlight the need for structured medico-legal orientation, morbidity and mortality meetings with non-punitive ethos, and clear internal protocols for handling complaints for adverse events. In conclusion, in India today, the choice between the defensive medicine and ethical practice is not merely a personal moral dilemma for individual doctors. It is a systemic design problem. An European researcher lady had found that those doctors gave more time to the patient to listen to their case, complaints, problems, suffering. They tend to be less sued. Ethical practice, by contrast, is aligned with legal standards articulated by our courts, and with the task before us is to create clinical environments, institutional cultures, and legal frameworks in India where doing the right thing for the patient is also demonstrably the most secure path of the doctor. If we can move in that direction through better education, fairer processes, and more open dialogue between medicine and law, navigating medico-legal realities will mean not choosing between ethics and self-protection, but building a system in which they finally converge. Now to conclude. I have a pleasure in presenting my second edition of the medical negligence book, What Doctors, Patients, and Hospitals Should Know, to Medharmony as a representative
of Medharmony. Yes. Thank you, Dr. Shinoy, sir. What a wonderful lecture. Thank you. Please give a big round of applause to Dr. Shenoy, sir.
I was addressed, the letter addressed to me by the Medharmony office says, Dr. P.D. Shenoy, turnaround specialist. So my book on turnaround strategies, I am presenting it to Medharmony conference representatives.
Thank you, sir. Thank you for all the thoughts. Clinical excellence.
In conclusion, I thank you for your patient hearing and taking interest in this conference. And we had very, very eminent speakers. I heard them with patience, and I learned a lot, I must admit.
Thank you. Thank you. Please give a big round of applause for Dr. P.D. Shenoy.
Dhanyawad.
Clinical excellence
Bhagwan aapko sukhi rakhe.
Ethical responsibility are indeed inseparable in today's healthcare environment. Thank you, sir, for the wonderful lecture. Thank you. Now we move on to our next speaker, Dr. Mahesh Baldava, senior pediatrician and medico-legal expert from Mumbai, and he's going to speak on mob violence. I would invite Dr. Parag Sancheti, sir, and I would invite Dr. Parag Sancheti, sir, and Dr. Aditi Karad to felicitate Dr. Mahesh Baldava. Advocate Dr. Mahesh Baldava uniquely combines active surgical practice with deep expertise in medical litigation and legal risk advisory, making him a distinctive authority in medico-legal space. He has handled a wide spectrum of cases, from defending institutions in negligent claims to advising hospitals on clinical documentation, consent frameworks, and standard of care compliances. Dr. Baldava conducts structured capacity building programs for healthcare professionals on legal awareness and proactive risk mitigation. His dual perspective as a practicing clinician and legal practitioner makes him an invaluable resource for the hospital leadership seeking to build legally robust, resilient institution. I welcome Dr. Mahesh Baldava. Please give a big round of applause.
Good evening, everyone. Am I audible? Now, this is what I have chosen the topic for the evening. Does the violence means in future defensive medicine? This is what we are going to discover. Leadership of the big hospitals or small hospitals should work at prevention, preparedness, and protection. No medical error or accident can be corrected by broken bones, shattered equipment, or terrified medical staff. These are the 12 books which are there on display outside, not for sale. This is our largest selling book. 9,000 books have been sold out. This is available on Flipkart and Amazon. This as well. Now, if the consumer case, as promised under Consumer Protection Act 2019, can be wound up with 90 days, remember, speedy justice will prevent violence. Our main ill is that we cannot dispense speedy justice. It is said that if all the courts have to wind up with all the cases, working 24/7, it will take 324 years as on date. Delay in justice is justice denied, and it will definitely incite violence because people want quick fix. Police delays, criminal justice delays result in violence because they want a quick fix. Mob wants to punish each sudden, unexpected, unpredictable complication, which even a doctor does not do so many times. Death and deformity. Mob violence is a quick fix for the delays in administrative police system and judicial machine. Lastly, even if you do in 90 days, then people will say justice hurried is justice buried.
Dr. Baldava,
Yes.
if I may interrupt you, just due to time constraints, kindly finish your lecture in 10 minutes time, please.
Should
Yes,
I,
yes, yes.
on this slide?
Yeah. No.
It will take
No,
another 10
no,
slides
no,
before.
no.
A nation that cannot protect its healers, slowly and steadily dismantling its own healthcare system to doom. This is a case study of Singhania Hospital where you know Mr. Anand Dige, who was declared dead, and the 5-star hospital got destroyed. Another, which is now in the news, is the Shastri Nagar Dombivli case. Mr. Ramesh Mhatre, whose bail has been cancelled. Here I have written he is free. He isn't free, but the High Court has taken the cognizance. This is referral. When we refer to other hospitals, referral is equal to refusal treatment. So the patient and next of kin perceive referral as if the hospital does not want to perform its duties and trying to shirk the responsibility. This is 2013. This was shocking, you know, that Kerala doctor, she was brutally attacked and she died. The hospital cannot provide safe medical care unless caregivers are protected. And in this case, Supreme Court observed, SC logic was that if we gave security to doctors, then they will have to provide security to lawyers and other professionals. This was illogical, but this was the logic. Why do these incidents happen? Most violent episodes look unprovoked, sudden, unexpected. Crisis due to gap, non-disclosure, absent forewarning about death, disability, potentially brewing up suspicion amongst the patient next of the kin, and growing anger, crowd formation, mob violence, and people's property, they try to damage. And no mind of its own, they just follow the instructor. Now, is mob violence the future defensive medicine? To my mind, in my personal opinion, it is yes. Unless we make quick justice, the mob violence is going to increase. Corporate hospital dialysis, guard, X-ray screening, and high expectations from corporate hospitals because of a large ticket size. The patient feels there is a huge money which is charged. Critical care decisions require SOPs for communication with respect to forewarning, disclosures, counseling, consent. Corporate hospitals management should be with SOP, not just react and hop from one incident to another incident, a violent incident. Safety should be promised. Violence is the doctor's problem. It is everyone's problem. So create SOP, organization preparedness protects everyone. Safety chain should be there and learn prevention of violence. Management responsibility. So corporate hospital leadership must ensure clear violence prevention policy, have security department teams and conduct mock drills, communication drills, disclosure, forewarning tricks and protocols, electronic emergency responses, and study flashpoints like complications wherever it is occurring, the death, the disability, prolonged stay, and huge uncleared bill. The myth is excellence prevents. Degree qualification of doctors on paper websites do not prevent violence. Even excellent state-of-art equipment will not prevent. Patient next of kin always remember only the bad things. Complications, death, disabilities, huge bills, and prolonged stay. So they do not fear the bad news. What they fear, they do not dislike, is sudden, unexpected news rolled out unceremoniously without background. So you must be prepared or anticipate the problems and disclose to them. And this is the clear rule. 7% is the language. 38% is the bad body language of the people who are around them. And that is 55%. And the bad body language is 38%. So remember, whenever people are there around, they aren't comfortable. And you aren't comfortable with them. Most likely they will gather the crowd. So never make them feel that doctors are great, patient next of the kin can never understand medicine. Communication is the first safety barrier. So always tell them possible complications, prolonged stay in the hospital, huge bill, amputation, vision loss, hemiplegia, paraplegia, incurable disease, loss of vitality, reaching to irreversible stage with respect to health. All things must be explained with respect to limitations of the medicine, treatment, and other pathies, and prepare the next of the kin to handle sudden and unexpected, uncertain outcome in advance. Anticipatory counseling is very important. Everywhere you should anticipate whether this patient's health is going to cascade to death, disability, or delay in the healing, prolonged stay, huge bill, and this should be explained. Be modest, try to be honest, and try to build trust. Forewarned doctor is a forearmed doctor. High-risk situations are ICU, resuscitation after ventilator, septic shock, cardiac arrest and resuscitation, supra-major hospital, NICU, PICU, bad obstetric history, and repeated counseling is required. Preparing patient for next of the kin for worst outcome of, don't give them unrealistic patient is critically ill, despite proper treatment, complications are occurring, and they are cascading and destabilizing the patient. This must be told. This reduces the sudden, unexpected shock and about the bad outcome and misunderstanding. The consent is more than a signature. So it keep on taking consent if the patient is becoming worse. So documented, courts and lawyers say if it is not documented on paper, it is not done by doctor. Means there is no evidence for treatment. Maintain records at least for 3 years. Good documentation is the best security and safety in the court. Poor documentation is poor defense, and no documentation, no defense. Documentation, there should be time, date, whatever the comorbidities must be written, and you should write specifically it's life-threatening, hemodynamically unstable, cytokine storm, MODS in much advance. So when treatment is refused, then you should take a negative consent. Medical protection law is an illusion. It cannot prevent a flying brick of violence. Police response is there is a delay in time gap, but at the same time, silence after violence is permission for the next attack. So speak today or more later. So call emergency number 100, it is essential. However, response time may be more. Corporate hospitals must manage their critical system. The digital flashpoint, this is the most important slide. Disagreement involving few people, they that you gather at this place, and in Ziffy, 100 of number of, they gather and they try to pressurize you, argue, and even might beat the doctor black and blue and damage the property. So personal safety, as I was telling in the question answer, you should have paper spray or maybe like something like a toy gun, which is just 900 gram costing about 6,000-7,000 rupees. Security is the corporate responsibility, and security guard myth. Guards are hired, unarmed, underpaid, ready to run away before the violence occurs. So more guards does not mean that there is more safety. So it is the good hospital design minimizes the confrontation, and you should have a rear exit. CCTV camera is another farce. Post-event you can analyze or give as evidence, but it cannot prevent the actual violence. After the incident, management should treat the injured and may document evidence preservation, police legal reporting. Every incident should improve future safety. Insurance you should buy, and all these insurance which I have discussed, fire, personal accident policies, and indemnity policy saves you from whatever you earned should not get wiped off. Medical legal safety triangle, that is communication, disclosure, forewarning, counseling, written refusal, consent, OPD, IPD, supported by strong managerial leadership by all types of protective. Final take-home message, violence prevention is not achieved by CCTV camera alone, security guards alone, insurance alone, police alone, legal system alone, but it's a collective effort. So remember that to prevent future defensive medicine, it requires that we should also contribute by preparing as a leadership, as a management, for safety of everyone, so that everyone is not afraid of the incidents of mob violence and resort to over treatment, over investigation, etc. Thank you very much.
Thank you,
Ignorance of law.
Dr. Baldava.
I hope I am.
Yes, yes, definitely, sir. Thank you. Thank you for keeping it short. Please give a big round of applause for Dr. Mahesh Baldava. Your practical insights will certainly help clinicians navigate today's increasingly complex healthcare landscape. And to conclude the academic proceedings and share the vision ahead for Medharmony, may I invite Dr. Parag Sancheti to address the gathering.
Everybody, and won't take long, won't keep you waiting more between my speech and dinner. Thank you everybody for coming. I think it was a very, very exciting second edition of Medharmony, and I honestly feel I was very, very impressed with Anupriya ma'am, the way she spoke, her elegance, her style of delivery, her knowledge when she was speaking about antibiotic resistance and microbial eminence. I think that is something which was very much the highlight today, and I want to thank her for coming here. We had Dr. Baldava, Dr. Shenoy, and of course our own panelist, Dr. Thakkar and Dr. Parvez Grant. Special thanks to them. Again, we had Dr. Sangeeta Reddy, who spoke so well. I think we will end this by thanking our main pillars of this conference. I want to sincerely thank Rahul ji. Rahul, thank you so much for organizing the second Medharmony. A big round of applause for Dr. Rahul and Dr. Aditi ma'am. You know, both of them have relentlessly worked for this program, bringing a minister here and making her speak. She's just come to Pune for our program. She's already in the flight back home. So that speaks a lot. Thank you, Rahul ji and Aditi ji, for making this possible. I think the second Medharmony has been a grand success, and we will now take steps towards the third Medharmony and make sure how it is going to be even better and better. So thank you all of you, and thanks the back-end team. You completely, the master of the ceremony was fantastic, so thank you so much. And I request all of you to please join us for dinner, and we will have further discussions on then. Thank you very much.
I'll just say thank you to Parag sir. It is collective discussion always. Always there is a guidance from Dr. Parag, and we will take it ahead along with you, sir. Thank you.
Please give a big round of applause for Dr. Sancheti. Before we break for our networking dinner, on behalf of the entire organizing committee, I sincerely thank our honorable chief guest, distinguished speakers, and most importantly, each and every one of you, the delegates, for making Medharmony 2026 a resounding success. Please give a big round of applause for you. Thank you. Thank you. Ladies and gentlemen, as we bring this enriching confluence of healthcare leaders to a close, this is Dr. Ramprasad Dharangutti signing off. Thank you for your time and your dedication to clinical excellence. Have a wonderful evening, and we look forward to welcoming you back for next year's Medharmony 2027. I request everyone to rise for the national anthem.
सिंध गुजरात मराठा द्राविड उत्कल वंग विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता